Now, in a minute we will start. Good job. Good afternoon, everybody. It is the first day of summertime in Jordan. I will be moderating this session and virtually with Dr. Ahmed Uthman, my colleague and my friend. And it gives me a great pleasure to welcome on your behalf Dr. Andrew Davis.
Thank you.
He has a lengthy and busy CV, but I will try to be short. Dr. Andrew Davis, he's a professor of hematological oncology in the Cancer Sciences Unit in the Faculty of Medicine, University of Southampton. He completed his training in medical oncology at St. Bartholomew's Hospital in London, and as a cancer research fellow in the UK, he underwent a PhD examining the molecular mechanisms underlying the transformation of follicular lymphoma to more aggressive histological subtypes. His main interest, and he specializes in the treatment of malignant lymphoma and the use of high-dose chemotherapy. He was chairing and he was the past chairman of the UK National Cancer Research Institute in high-grade lymphoma study group. Dr. Davis will be talking about treatment of relapsed aggressive diffuse large B-cell lymphoma. So on your behalf, I welcome Dr. Davis.
Thank you so much for such a kind invitation, and good afternoon, everybody. I'm afraid that the summertime also confused me a little bit, so I'm here now, and it's great to be with you all. I'm just going to put my share screen on, so I just want to make sure that everybody can see, and I hope that you can hear me okay. So in the next sort of 30 minutes or so, what I want to talk about is the sort of new approaches to the management of relapsed and refractory diffuse large B-cell lymphoma. And it's a great honor to be part of your meeting today. So I have a number of conflicts of interest that I just wish to state. I do a lot of novel drug development, and so obviously there's a lot of interaction with the pharmaceutical industry. So diffuse large B-cell lymphoma, commonest of the B-cell lymphomas, our expectation of success is high. And you know, if we look at clinical trial data, about 80% of patients will be alive 2 to 3 years after diagnosis once they're in clinical trials. Now, underlying that is the fact that, of course, patients who go into clinical trials are somewhat more of a selected group, and often we don't recruit patients with significant comorbidities or at the extreme of age, for example. So if we look at population-based statistics, we'll find that about 60% of patients are alive 2 to 3 years after completion of therapy. And really what we say is that unfortunately about 40% of our patients with diffuse large B-cell lymphoma are being failed by our current therapeutic approaches. So there's a real need to improve the outcomes for these groups of patients. Now, of course, we can identify quite well which patients are going to do well and which patients are going to do less well. And we can do this very simply by using clinical prognostic parameters. And the commonest of all the scoring systems is, of course, the International Prognostic Index, which uses 5 simple clinical variables. And we know that those patients who lack any of those adverse features have an excellent outcome, and probably we can cure over 90% of those patients. However, those patients who have multiple poor prognostic factors, such as the presence of older age, extranodal sites, high stage disease, high LDHs, approximately only 50% of those patients are being appropriately managed with our current therapies. So on top of that layer of clinical prognostic scoring, we can also try and identify the patients who are going to do well and the patients who are going to do less well by applying some biological stratification. And I think those of you looking after patients with diffuse large B-cell lymphoma will recognize this molecular heterogeneity that's been described, and this data that looks at the transcriptional profile of diffuse large B-cell lymphoma. And we recognize that those patients who have a transcriptional profile that's similar to germinal center B cells, they have a better prognosis than those patients who have a diffuse large B-cell lymphoma that has a phenotypic resemblance to activated B cells in the peripheral blood. And that's the so-called cell of origin model. But layered on top of that, you can look at information about overexpression of MYC and BCL2 proteins, and that portends a poor prognosis, and particularly those patients who have translocations involving MYC and BCL2 and or BCL6, the so-called double hits and potentially the triple hit lymphomas. Those patients have a worse prognosis and are likely to be heading for a poor outcome with conventional induction therapies. Now, of course, what we've tried to do over the last few decades is to try and build upon R-CHOP chemotherapy to try and improve outcomes. So the number of people whose disease fails induction chemotherapy should be reduced. However, despite really tens of thousands of people going into well-conducted clinical trials, really we've failed to significantly push on the bar in terms of modification of our frontline therapy. So we've tried to use additional drugs and more complicated regimens. We've tried to intensify therapy with high-dose chemotherapy and stem cell rescue. We've tried different antibodies to partner with CHOP chemotherapy. We've tried different drugs that maybe target pathways that are dysregulated in large B-cell lymphomas, such as lenalidomide or ibrutinib, all of those with the hope of trying to push on the outcomes that we can get with R-CHOP chemotherapy. But largely those strategies have generally been unsuccessful to date. And the reason for that, and reason why that this ability to try and explore and exploit these different biological groups is because probably there's a much greater degree of complexity in the heterogeneity of diffuse large B-cell lymphoma than actually we'd hitherto recognized. And trying to group DLBCL into one single disease entity is clearly a massive oversimplification. I think if we apply complex genomic strategies such as whole exome sequencing, assessment of copy number variants, assessment of structural variants, and layer that with transcriptional profiling information, what we recognize is there are a much greater number of subclasses of diffuse large B-cell lymphoma. And each of those different classes have a different landscape of genomic oncogenic vulnerabilities that maybe we can potentially target in the future. So I'm really clear that our way to unravel the problems with failure in DLBCL is to clearly understand the biology much more. And our understanding of the biology of relapsed diffuse large B-cell lymphoma is really very poor at the moment. We understand that there may be acquisitions of further mutations that define a group of patients who have relapsed disease or refractory disease. And those mutations may include, for example, accumulation of epigenetic mutations such as CREB-BP or TP53 mutations, but really we don't clearly understand the biology. And I really believe that understanding the biology better of diffuse large B-cell lymphoma will not only result in us the prevention of people failing, but also us being able to better manage the relapsed and refractory disease population. So what's our clinical approach to the management of this problem of patients with relapse and refractory disease? And really, most simplistically, in the past, we've simply divided patients into, are you young and fit, and can you withstand intensive reinduction chemotherapies? Or are you older with comorbidities, perhaps, where it's not appropriate to offer intensive reinduction strategies, and your approach is much more towards active palliation of the disease. Now, actually, in recent years, we've recognized that there's probably a third state that sits somewhere in the middle, where there are patients who are probably not fit enough for intensive reinduction therapies and stem cell transplantation, but actually that might be fit enough for some of the cellular therapies. And I'm going to come back to that a little bit later in my discussion. So the first thing I want to do is just to explore how we might manage relapsed DLBCL in our younger, intensive fit patient population. And really the foundation for what we've done up until now has been this study, the Palmer study, that was published in 1995. And it compared the use of standard reinduction chemotherapy in patients with relapsed disease to standard therapy induction followed by stem cell transplantation with peripheral blood progenitor cell rescue. And you can see from the graphs that using high-dose chemotherapy was associated with a prolongation in both progression-free survival and overall survival. And this data really cemented the use of high-dose chemotherapy in second remission as our approach to managing patients with diffuse large B-cell lymphoma that had relapsed. And we'd asked ourselves quite a lot, what was the best chemotherapy to use after R-CHOP had failed? And of course, we used non-cross-resistant chemotherapy. And there are many different recipes that we can look at in the book: DHAP, ESHAP, MIME, ICE, GDP. And they're all trying to achieve a remission, and they're all trying to achieve a remission with minimal toxicity, and they're all trying to achieve a remission that doesn't compromise the ability to collect peripheral blood stem cells. The CORAL study is an important randomized study that compared two potential reinduction regimens, R-ICE with R-DHAP. And you can see from these curves that there was no difference in outcome between the different regimens. So what I say to people is that you can choose what you feel most comfortable with delivering and what suits the logistics of delivery in the centers that you work in. Another alternative is to use the GDP regimen, so that's gemcitabine, cisplatin, and dexamethasone. And when this was compared with DHAP chemotherapy by the Canadian NCI group, again, we saw no difference in outcomes between the different chemotherapeutic strategies. Perhaps the quality of life was better for those patients who received GDP. And so for many territories, GDP has become the standard reinduction regimen with rituximab in patients with relapsed and refractory disease. And this is because it can largely be given as an outpatient, and largely it has less impact upon the patient's quality of life. But as I say, I always tell physicians, use the regimen for reinduction that you feel most comfortable with. We've looked at whether changing the antibody partner with the chemotherapy can improve outcomes. You know, these patients have all been exposed to rituximab before, and do you think that if we use a different antibody treatment, then we might improve upon our outcomes? Well, using obinutuzumab in this large randomized phase 3 study, the Orchard study, was not associated with any improvement in outcomes compared with the use of rituximab. Sorry, I should say ofatumumab. So the question is what are our expectations of outcomes for these patients with relapse? Well, unfortunately, for those patients who relapse early in the context of prior exposure to rituximab, our markers of success and our outcomes are really very limited. And actually, event-free survival for those patients who progress within 12 months is less than 20% at 1 year. So we've really got to do better for these patients, and we've really got to find strategies that are better. Now, I'm often asked is in patients who have primary refractory disease, so those patients who grow through R-CHOP chemotherapy, or for those patients who relapse very early after R-CHOP chemotherapy, is one chemotherapy second line regimen better than another? Should I be using regimens that contain high dose cytarabine? Now, there's no randomized data in this setting, but there are some retrospective series, and they suggest that the outcomes are really the same whether you use a cytarabine containing regimen or you don't. So I would say to you, for refractory and relapse patients, really treat them in the same way as each other. And what about the role of high-dose chemotherapy in patients who have had primary refractory disease? So if you can get patients with primary refractory disease into a second remission with a reinduction regimen such as GDP or RDHAP or RICE, there's a really strong rationale for continuing to move those patients through high-dose chemotherapy and stem cell rescue, because they have very good outcomes and are very similar to the outcomes that can be achieved by those patients who have just relapsed disease and have been primary sensitive to R-CHOP chemotherapy. Now, I'm often asked also whether there's a role for high-dose chemotherapy in patients who didn't get a complete response to their reinduction therapy, but had a PET positive partial response. And actually, we can see from data from a number of registry series that those patients who have a PET positive partial response actually have very good outcomes. And although they may have a risk of early failure, if they remain in remission, their outcomes are really just as good as those patients who have a CR with therapy. Now, I take this data very cautiously and take a very individualized approach to this. So for patients who after reinduction therapy have some residual small volume disease, then I'll be very happy to take those patients to high dose chemotherapy. But for those patients who have disease that has relapsed and is persistent at multiple sites, then I look for an alternative strategy for those. So although we recognize that we can have very good outcomes for patients who have a PET positive partial response, it's not really for everybody, and we have to be very cautious about who we choose. The other question about high-dose chemotherapy that's often asked is the role in our elderly patient population. And it wasn't so long ago that 60 was our upper limit of acceptability for safety of high-dose chemotherapy. But of course, now we do this for very many people in their 60s, and we're doing it for more and more patients who are in their 70s. Yesterday, I saw someone who had been referred who was 74 for high-dose chemotherapy. And I think that these patients can do really well with high-dose chemotherapy, and they have really excellent outcomes. But really, this is all about patient selection and individualization of decision making. I think what's really important if you're going to think about high-dose therapy in older patients is you think about selection, assessment of their physiology, optimization of supportive care, and importantly, thinking about their trajectory of functional recovery. What I mean by that is how long it's going to take them to get better after they've had the procedure. You do this for somebody who's in their 30s and 40s, and they bounce back and they're at work, 6 weeks after they've had the procedure. For elderly patients, they often spend a lot longer period of time in the hospital and a lot longer period of time recovering afterwards. But for certain individuals, high-dose chemotherapy clearly has a role. Now, unfortunately, if you relapse after high-dose chemotherapy and stem cell rescue, your outcome, unfortunately, is disappointingly poor. Now, we have available an effective third-line option now. Now, of course, there are clearly economic restrictions on this, and there are territory restrictions on this, but third-line use of CD19 directed CAR T-cell therapy has been a big step forward for us. And we know that there are 3 approved products currently, Captogene, Tisagen, and in some territories, Lysocell has been approved. And the data really demonstrates that for those patients who are fortunate enough to have the CAR T-cell re-infused, that we can see long-term durable responses. And although the overall response rates may be sort of, in excess of 60-70%, many people do fail very rapidly afterwards. And for those patients who are in remission at 6 months, one can expect durability of benefit. And what's really exciting has been to see this year at the ASH meeting, the long-term follow-up from the pivotal study of Axicell, which now comes with 5 years of follow-up. And really what's really exciting is that 43% of patients are alive 5 years after having had CAR T-cell product. And don't forget, these are patients who were treated in the third-line setting. So if you are lucky enough to get to a CAR T-cell center and you are lucky enough to have disease kinetics that allows the timing of manufacturing of the CAR T-cells, and you're lucky enough to get a good response, actually these patients can enjoy really durable responses, even if they've had multiple lines of prior therapy. And this data that we saw from the follow-up of the Zuma-1 study is particularly important for those patients who remained in remission for 2 years after having had their CAR T cells. And actually for those patients, over 95% of these patients are alive in long-term follow-up. So really very durable responses can be achieved in the third-line setting for this group of patients. Now, when we look at real-world data rather than clinical trials data, we can see that the CAR T cells are behaving in a very similar way to has been seen in the pivotal study. This is data from the UK, for example, which shows curves that are very similar to the pivotal studies. And this includes patients who may not have generally gone into some of the other studies. Now, we recognize that there are some toxicities associated with CAR T cells that we have to recognize. These include cytokine release syndrome and neurological toxicity that can happen within the first days post reinfusion and require clearly specialist care. But actually, there's a lot of long-term toxicities that we need to think about in patients who have had CAR T cell therapy. And it's important as these patients come back to us from the CAR T cell reinfusion centers. Many patients have prolonged cytopenias and will need blood product support and maybe growth factor support. And of course, B cell aplasia can also be prolonged, and this can result in problems with recurrent infections. And about 40% of patients in long-term follow-up have required immunoglobulin replacement. And that's obviously a demand upon our resources and our time in referral centers. So I think we need to think very carefully about the patients as they return from CAR T cell centers. Now, of course, with the success of data of CAR T cells in the third-line setting, it was only natural to try and push CAR T cells up into the second-line setting, and also given that our high-dose chemotherapy regimens and success in that group of patients has been so disappointing. 3 randomized studies have now been conducted comparing standard of care, i.e. reinduction therapy with high-dose chemotherapy, to CAR T cells in patients who have relapsed and refractory DLBCL less than 12 months after diagnosis or after completion of their initial therapy. And these 3 studies were reported at ASH this year and are going to have a profound impact upon our approach to the management of relapsed and refractory diffuse large B-cell lymphoma. They all have a very similar design. There are some subtle differences in the endpoints and the processing that goes on, but essentially the results of the study that looked at the use of Axicel from KITE showed a superiority in the primary endpoint of event-free survival in those patients who received CAR T cells compared with those patients in the lower red line who had standard of care reinduction therapy. And the hazard ratio on this curve was 0.398. So a really significant reduction in the number of events. So a clear win for CAR T cell therapy in the second line setting. However, when we look at the overall survival, there was no difference in outcomes in terms of overall survival between the two groups. And the reason for this is that the number of patients who had the standard of care arm, 56% of those switched over to receive CAR T cells in the third line setting. So really a clear advantage for CAR T cells in second line therapy. Now, this data is backed up by an interim analysis from the Transform study, which looked at a different CAR T cell product, Lysocell. This is a Celgene product. And although their study was smaller, and this is just an interim analysis, once again, CAR T cells were favored over standard of care for the primary endpoint of event-free survival. Now, a third study has just caused a little bit of chaos in the mix, and that's the Belinda study, which compared another CAR T cell product, Tuzumab, with standard of care. And you can see from the graphs here, the Tuzumab was shown in the blue, the standard of care is shown in the origin, and there was no difference in event-free survival. Now, the time from apheresis to reinfusion with this product was much, much longer, and the median time was some 52 days, and there were some differences in the endpoint, and the product may well be different in terms of its activity. So a win for 2, one of them unfortunately hasn't won. But for patients who have early relapse of diffuse large B-cell lymphoma, I think few of us doubt that CAR T-cell therapy is going to be the approach to second-line therapy rather than autologous stem cell transplantation. Now, of course, what that means is a complete switch in the way our treatment algorithms are. And, what we'd probably do is we'd probably lose a line of therapy, because although we think that we can effectively deliver CAR T cells after failure of autologous stem cell transplantation, the reverse is not true. So we are not able to do autologous stem cell transplantation after failure of CAR T cells. So that means we lose a line of therapy. And also, patients to treat at relapse after CAR T cell therapy are really difficult. And that's because they have these cytopenias and they have those infections. So delivery of further therapies after this is going to be a real problem for our patients. So there are other approaches that we're thinking about in terms of CAR T cell therapies, in terms of reducing the risk of failure of CAR T cells. One of those is a CAR T cell, for example, that targets 2 antigens on the surface of the malignant B cell, CD19 and CD22, for example, but also perhaps using allogeneic CAR T cells, where the actual T cell is harvested from a normal healthy donor and then modified. So these CAR T cells are ready to go, so you don't have to wait around for the manufacturing process. So that speeds up exposure for the patient, and also you're reinfusing abundant, healthy, fit T cells that may have a better response against the tumor than some of those T cells that have been taken from the patient who may have been exposed to multiple lines of chemotherapy. So there's lots of work being done on trying to resolve this situation for CAR T cell failure, but it's all very, very interesting. What we recognize is, as I say, treating people after CAR T-cell therapy is very difficult, and few regimens result in long-term effectiveness. Lenalidomide may be a useful treatment, but generally chemotherapy is not. So that's probably our approach now to the younger, fitter patient. There is a group in the middle who aren't fit enough for high-dose chemotherapy because of age, but actually are probably fit enough for CAR T-cell therapy because they may tolerate this much better. And for those group of patients, what we do at Relapse is we give reinduction therapy. We wait to see what happens. We recognize that many of those patients will fail, and then we bring in CAR T-cell at third line in those patients. But I hope that we're going to be able to shift this up and be able to push the CAR T-cells to second line as the approvals come through, hopefully later this year. Now, for those patients who are older and frail, who don't have the ability to access or tolerate CAR T-cell therapies, our regimens at Relapse have been sort of numerous over the years, and we've used doublet and triplet chemotherapies. And one of those is gemcitabine with oxaliplatin and rituximab. It has response rates of 50 to 60%, but unfortunately, few patients enjoy durable responses. Very similarly, the bendamustine and rituximab combination again has response rates of about 50 to 60%, low numbers of patients with CRs, and again, very few people enjoy durable remissions unless they've had a very good remission prior to that. And if we look at the effectiveness of R-GemOx to R-bendamustine, this is simple registry data. Both of those regimens tend to be similar, and you can see from those survival curves that there's a very steep decline within the first year of initiation of therapy and a very low tail there afterwards. So we've been really focused on trying to improve outcomes for these patients. And I think we're pretty fortunate in diffuse large B-cell lymphoma in that there's a whole range of new potential therapies beyond the cellular therapies that may potentially be targetable and may potentially be brought to market for patients with relapsed DLBCL. So there are pathways that are dysregulated, and there are various drugs that may affect these dysregulated pathways. There are also a range of different cell surface antigens that we can target with either naked antibodies, antibody drug conjugates, or bispecific antibodies. And this is causing a huge amount of excitement. Now, Tuzumab is an antibody drug conjugate that has been approved in very many territories for relapsed and refractory diffuse large B-cell lymphoma. The antibody backbone is to CD79B, which is a component of the B-cell receptor. And the antibody carries with it a payload of a cytotoxic called monomethyl auristatin, or MMAE. And this is the same cytotoxic payload that we use in brentuximab vedotin for Hodgkin's lymphoma. And the MMAE is linked to the antibody via cathepsin B linker. So this antibody drug conjugate is given intravenously. It localizes to the malignant B cell by binding to CD79 and is then internalized. Within the lysosome, the acidic pH results in cleavage of the linker and release of the active MMAE, which causes microtubular disruption and subsequent apoptotic death of the cell. CD79B is expressed on over 95% of malignant B cells, so it's a really strong target. Now, this drug in single agent or in combination with rituximab has some very good activity, but a low number of complete responses. And complete responses are clearly very important in diffuse large B-cell lymphoma. So Polatuzumab was partnered with chemotherapy in the hope of trying to improve outcomes. And this important randomized study compared bendamustine rituximab to Polatuzumab with bendamustine rituximab in patients who had non-transplant eligible diffuse large B-cell lymphoma. Now, it's a small study, it was just 40 patients, but the primary endpoint was metabolic complete response rate. And we can see in the orange, that's the metabolic complete response rate for those patients treated with bendamustine rituximab. But in the blue, we see those patients who received chemotherapy as well as polatuzumab. And you can see that there's a significant improvement in complete response rates. And this came at really minimal difference in terms of toxicity. There was a bit more neurological toxicity and a bit more neutropenia, but all of these were very manageable. And there's a difference not only in terms of response rates, but a clear superiority in progression-free survival in favor of the polar BR combination, and a significant improvement in overall survival as well. Now, this is regardless of the level of CD79B expression on the B cells, and also it's regardless of the cell of origin or the presence of MYC overexpression in our patients. Now, that has resulted in the planning of various other studies that looked at polatuzumab in combination with chemotherapy. We're currently looking at adding polatuzumab to R-ICE chemotherapy in patients with transplant eligible disease. And of course, you will know the frontline data of polatuzumab added to R-CHOP chemotherapy is associated with an improvement in progression-free survival. Now, there are some other interesting antibody drug conjugates that are being applied in relapsed and refractory diffuse large B-cell lymphoma. Lonca-T targets not CD79B, but CD19, which is almost ubiquitously expressed on the malignant B cell. And this has a different conjugate that travels with it. And the data is very favorable in terms of response rates as a single agent, with overall response rates of 50% and CR rates of 25%. And some of those have been durable. We've also seen the use of a CD19 monoclonal antibody that isn't an ADC, but just a naked antibody, which is tafasitamab. And this is a humanized monoclonal antibody that actually has enhanced antibody-dependent cellular cytotoxicity activity. And this is given in combination with lenalidomide for patients who are non-transplant eligible, and has been associated with response rates of nearly 60%, and again, some highly durable responses. So this has been approved in some territories and is going through the approval processes in many other territories, and is a useful therapy to consider. And of course, we're very much excited by the use of bispecific monoclonal antibodies. So these bispecifics target two antigens simultaneously. And there are 4 drugs that are in later stages of clinical development that target CD20 on the surface of the B cell and CD3 on the surface of the T cell to form an immune synapse, so opposing the T cell and the CD20 malignant B cell. And that causes activation of the T cell and T cell mediated death of the malignant B cell. And there are a number of studies that have demonstrated activity in aggressive lymphoma, and we see overall response rates of about 50%, and some of those responses appear to be durable. Now, what we do notice is, of course, this is T cell activation, so there's a risk of cytokine release syndrome, and some of these drugs are given in slightly different ways to mitigate that risk of cytokine release syndrome. But no doubt we'll be seeing the availability of bispecifics in diffuse large B-cell lymphoma in the coming future. So just in the last minute or so, what I want to say is that, whilst we have all these exciting new therapies for relapse and refractory diffuse large B-cell lymphoma, what we want to do is get much better at identifying failure early. And so we want to make sure that we can look at biological risk factors and clinical risk factors at the beginning for our patients, and that we can look at therapy as we go along and see how PET scans change and see how cell-free DNA changes, so that we might be able to bring in these additional therapies much earlier than we're currently doing at the moment, and not wait for our patients to get primary refractory disease or to relapse, but actually to try and risk adapt our therapies according to the dynamic response of the patient. And I think this is the way the DLBCL field is clearly moving. So unfortunately, historical outcomes for relapsed and refractory DLBCL have been poor with conventional chemotherapeutic approaches. And I think the cellular therapies are really exciting and are clearly of value if you're fortunate enough to be able to access those and have disease kinetics that's suitable for you to wait for the manufacturing process. There's lots of new exciting antibody drug conjugates. There are lots of exciting bispecific monoclonal antibodies as well. And I think what we really need to do is we need to understand better the biology so we can know how best to use these exciting new tools. Thank you very much.
Dr. Davis, I would like to thank you for this very informative and updated talk. And the floor is, we have space for a few questions. If there are no questions, can I ask you, what would be your, in order, after failing high-dose chemotherapy, would you go for, as we understand, for CAR T cells treatment versus autologous stem cell?
Yes. So if we have a patient who has failed autologous stem cell transplantation, then I would favor CAR T cell therapy for those patients, assuming that they were fit enough to be able to do that, and also assuming that they would be happy to travel to a CAR T cell center and that they would be happy to withstand some of the, the intensities of treatment and also the toxicities of treatment and perhaps some of the long-term toxicities of therapy. There are some patients who find that very difficult, patients who come from geographically remote areas, some patients who really aren't wanting to access CAR T cell therapy. So for those groups of patients who don't want to have intensive treatment, for most patients I offer BR Polar or often lenalidomide for those groups of patients, depending upon really what they want to achieve.
Can I have a question, please? Now, do we need actually to segregate the aggressive DLBL into two groups? You know, the non-GCB and GCB. We know that the non-GCB variant is less responsive to the R-CHOP. Do we need to segregate them and then tailor our treatment from the offset accordingly?
I think that's a really good question. I think, we have seen with some of the studies that I tried to point out that we've tried to modify the ABC phenotype, and we've tried to improve the outcome for those groups of patients with adding drugs to the R-CHOP backbone. And that's been a kind of a universal failure. So you think, well, actually, what's the point in doing this? Because your choice of frontline therapy is not changing. But I think that there's quite a strong feeling within the lymphoma community that we retain this biological classification because, in most studies, it retains some prognostic information. It may not be as prognostic as, perhaps some of the initial studies had reported, but I think it helps with prognostically. And I think some of the therapies that relapse that might not be accessible to everybody, it might help guide the use of those. So we think of lenalidomide, for example, as a much more ABC specific drug than a GCB. It might help guide you a little bit when you're thinking about alternative therapies. But I would certainly agree with you. The absolute need for it is really significantly diminished. However, I will say that in the next version of the WHO classification, that requirement for our pathologists to report whether it's ABC or GCB will be retained, because there's still quite a lot of pressure for people to understand which cell of origin classification it belongs to. And some of the more complicated classifications based upon genomics, so based upon mutation data, it's such a long way away from clinical utility, because these processes take time, these categories need to be validated, etc., that actually, we won't be using classification based upon these subclasses for a long time. And it just gives us at least a framework for us to think about and understand to some degree the molecular heterogeneity in the disease. But your point is very valid.
And another question, please. Can we use CAR T cell therapy as first-line treatment in double hit or triple hit DLBL?
So there is nowhere globally where this is licensed in the frontline setting, but there was a really interesting study that was presented at ASH this year, the ZUMA-12 study, and it took ultra high risk patients who were not doing well with R-CHOP chemotherapy and offered them CAR T cells as a frontline therapy. So they identified in this method of dynamic risk assessment patients who had double hit lymphomas or patients who had high IPI scores. And they gave those patients a couple of cycles of R-CHOP chemotherapy, and then they did an interim PET scan. And if the interim PET scan was still positive, this is portending a very poor prognosis. Those patients became eligible for CAR T-cell therapy as a frontline therapy. And the data from those patients who went on to receive CAR T-cells demonstrates a high complete response rate, and to date our understanding of durability of response. But absolutely this approach of saying, look, let's do our best to identify poor risk patients early, let's pull them out and say, look, there's no point in keep going on with R-CHOP chemotherapy. Let's give a cellular therapy to those patients, I think is absolutely right. And I think that you'll find, although in the past we've said high-dose chemotherapy doesn't work in the frontline setting, I do believe that we will in the future be offering cellular therapies to our highest risk patients with multiple biological and clinical adverse risk features.
And if there are no other questions, can I have a further question, please?
Of course.
Now, what's the role of combining, what's your view in combining checkpoint inhibitors with dual CAR T-cell therapy? Is there any role for that?
So of course, the mechanisms of failure of CAR T cell are multiple, but one of those is tumor that escapes without antigen, so you lose 19 expression, and one of those is just exhaustion of the T cells. So giving a checkpoint inhibitor is given with the point of trying to rejuvenate the T cell and energize it and make it fitter. And there are multiple studies going on at the moment that are adding a checkpoint inhibitor to CAR T cells. In many standard protocols, they're adding a checkpoint inhibitor. I think it's quite difficult without randomized data to know that, and we know that we've all had experience of giving checkpoint inhibitors to people who've relapsed after CAR T cells, and they've induced a remission quite amazingly. So I think theoretically the science behind it is right. I think the clinical proof of the concept has really yet to be shown, but that's not for people wanting to try and demonstrate it.
Can I have a question?
Yes, please.
Yeah, this is Dr. Halala. Thank you very much, Dr. This is a very interesting subject. Yes, relapsed diffuse large B-cell lymphoma are difficult to manage. It came to my mind two questions. The first question, for those who relapsed early on in the first 12 months post-autologous bone marrow transplant, allogeneic is not working. I know the standard is to do CAR T cells, but do you have in mind something to do in our area? We don't have CAR T cell. We have only Ric-Allo, and I think Ric-Allo is not working. And my second question is listing the 3 or 4 studies of CAR T cells in the third line. As long as I know, patients with CNS involvement were excluded from these trials. Do you aware of any data regarding the use of CAR T cells in the LBLs with the CNS involvement? Thank you very much.
Yeah, thank you. I'm really sorry, you're very faint, but I think the two questions were, number one, is there still a role for allogeneic transplantation in diffuse large B-cell lymphoma? And number two, what's the role of CAR T cells in patients with CNS disease? So I think the first question about the allogeneic transplant, yes, and I think we need to think about access and all the rest of it. The kinetics of diffuse large B-cell lymphoma and the pace of growth of the disease has never really been terribly suitable for a Ric-Allo, just in terms of trying to achieve a period of time where the disease is stable enough to actually get that benefit of graft versus lymphoma. So we recognize that there are clearly some people who will have a benefit from allogeneic transplantation, and my approach in the days before CAR T cells was in patients who failed or were failed by autologous stem cell transplantation, was to offer those patients allogeneic transplantation if you could get them into a stable third remission. And I absolutely believe that there are people who don't want to travel or can't access CAR T cells, that's still a very sound thing to do. But actually, we do recognize that a CAR T cell is a much safer approach than allogeneic transplantation with much less therapy-related mortality. So I do think there is still a role. The other role I think is that potentially in patients who relapse after CAR T-cell, and I've done this a few times now, people who've relapsed after CAR T-cell who achieve a remission with whatever therapy you use at relapse post CAR T, get into a stable disease state and then go on to have an allogeneic transplant. And for some people, you know, and there was data presented at ASH this year, it's small numbers, but they can enjoy, you know, a good outcome and a potentially curative approach. The data for CAR T in patients with CNS disease is small. However, it's pretty exciting. And actually, there are people with relapsed CNS disease who have had CAR T cell exposure. And for some of the studies in the pivotal study, they have enjoyed a clear response. So I do think that there is activity. We're currently doing studies at the moment looking at the use of CAR T cells in primary central nervous system lymphoma. So I think absolutely there's an avenue for cellular therapies in patients with either primary or secondary CNS disease.
Because I think we are running short of time. Thank you for your excellent presentation. And it was very nice to have you. Thank you.
Thank you. Enjoy the rest of your meeting.
Thank you very much.
لخصت السي في لخصت السي في عشان جزيرة أعطيك الفرصة.
Hello.
احنا كيف من الموت كيف من الموت
Yeah, hello.
بس لا تخشى تحمل اوكي Hello, Dr. Vincent.
Yeah, hello. Can you see me? Can you hear me?
Yes, I'm seeing you. Can we start introducing Dr. Vincent? Yes. So it's my pleasure to introduce me and Dr. Nazar Busul to introduce Dr. Mark Vincent. He is a professor, Division of Medical Oncology, University of Western Ontario, Canada. His clinical work is a medical oncologist at London Health Science Centre, Department of Oncology, part of Cancer Care Ontario. His activities include the management of lung and GI cancers and lab research into the reversal of cytotoxic drug resistance by means of gene therapy. He has many publications in prestigious journals, more than 120 articles. He's a book editor and reviewer in many books. He's a speaker at many conferences. He has many honors and awards, and he is active in research, which has spanned into 4 activities: drug design, toxicity prediction, biological nature of cancer, and disease site teams. He is the PI of many clinical trials, and we are happy to have him today to have a talk on updates of the management of metastatic small cell carcinoma. And Dr. Vincent, the floor is yours.
Thank you, Mr. Chairman. I appreciate the opportunity. Thank you to AstraZeneca for making this possible. These are my disclosures. And just to know what the audience is probably familiar with, I'm just going to go through a little bit on small cell lung cancer. Generally, it's about 15% of cancer and falling in incidence. Actually used to be 25, now down to about 13% in North America, strongly, of course, associated with smoking. Has a very characteristic histologic picture, as you can see here. small cells with scant cytoplasm, granular nuclear chromatin, extensive necrosis, high mitotic count, high Ki67 neuroendocrine differentiation with synaptophysin, chromogranin, and so on. Under electron microscopy, which we don't do today, but you can see neural enzymes, peptides, and transmitters in these dense core granules. About a third of them are limited disease. 2/3 of them are metastatic or extensive disease that is spread outside a single radiation portal and is felt to be more distant. And you can see how this is very hypermetabolic. It tends to take up on a PET scan, generally has central tumors with spread in liver, bone, adrenals, often the brain, and mediastinal lymph nodes. So the treatment has been for limited disease, chemoradiation, and extensive disease, chemotherapy with palliative radiation as required. And the regimen that has been mostly used is a combination of platinum and etoposide. But there are many regimens that are effective, including various kinds of alkylating agents, either platinum, and it could be combined with drugs like etoposide and irinotecan, but also older drugs such as cyclophosphamide, doxorubicin, the vinca alkaloids, methotrexate are fairly effective. There's been a long-standing debate about cisplatin versus carboplatin. In the extensive disease, small cell lung cancer, the outcomes are more or less the same, and you can see the median survival is almost exactly the same at about 9.5 to 10 months, either cisplatin or carboplatin. There was some interest in the combination of irinotecan with the platinum from Asia, where it was felt to be better, but this was repeated in the United States compared to standard etoposide platinum, and there was really no difference. These older combinations are active as well, but the standard of care remains platinum etoposide if you can get access to it. Small cell lung cancer, traditionally an extremely chemosensitive disease, at least initially, with limited disease response rates about 80% and certainly at least 60% in the extensive disease setting. And the NCCN guidelines endorse platinum etoposide, and with radiation, limited disease, and PRN radiation, you can use growth factors to support the blood count. Sometimes a very good idea. In extensive disease, the recent addition of atezolizumab, which is a PD-L1 antibody, has been endorsed by the NCCN. But as I'll show you later on, there's also endorsement now for the use of durvalumab, which is another PD-L1 antibody. And certainly radiation is an effective modality. It's a very radiosensitive disease. Certainly in the setting of limited disease, it will increase the cure rate. And you can see that here, that the cure rate is improved from chemotherapy alone by about 5 or 6% by the addition of radiation. The role of radiotherapy in extensive disease for chest radiation is somewhat unclear. We tend to do it in people where the dominant disease is within the mediastinum, and the rest of the disease is relatively minor. We think quite seriously about adding thoracic radiation onto people with extensive disease, but the goal there is not curative intent, it's really disease control. So there isn't a lot of evidence that it should be done routinely in everybody. The other modality that we employ both in limited and extensive disease is prophylactic brain radiation. There's a very high risk of brain metastases in small cell lung cancer, whether limited or extensive. And this is known to improve the control, the survival to a certain extent, but also if you look on the right here, the incidence of symptomatic brain metastases is quite markedly reduced by prophylactic cranial radiation. And in extensive disease, it was initially used in limited, but in extensive disease, there is some evidence from Europe that there's a modest survival benefit from prophylactic cranial radiation, and from Japan as well, showing the improved survival in extensive disease patients with prophylactic brain radiation. There are, of course, there's a downside to prophylactic cranial radiation in terms of memory loss and so on that I'm not going to get into now. So it is a discussion with each patient. Bottom line is that most patients, approximately 80% with limited disease, and almost everybody with extensive disease is going to relapse. The median progression-free survival is only about 4 to 6 months after first-line treatment. And there are very few people who will be surviving 5 years, even with limited disease. It's about 5% in men and about 8% in women. And the older you are, the less likely you are to have 5-year survival. So there has not really been much in the way of progress in small cell lung cancer for a very long time. The platinum etoposide regimen emerged in the 1980s. thoracic radiation became entrenched shortly thereafter. Topotecan IV was established in the mid to late 1990s. Carboplatin was established as an alternative to cisplatin. There have been various different radiation schedules and regimens and dosing. Basically, there's really been nothing that's really shifted the needle until the emergence of immunotherapy fairly recently. So this is the standard of care, platinum etoposide, as I've said, and essentially you can, you know that you're going to be faced with retreatment for these people when they relapse, if they're fit enough, providing there's been more than about 2 to 3 months since the last chemotherapy, and you can re-challenge them with platinum etoposide or administer topotecan. What about the molecular revolution that was going to solve the cancer problem? Well, unfortunately, it hasn't. It certainly hasn't solved it in small cell lung cancer. We know that there are consistent abnormalities, particularly MEK overexpression in about 30%, c-KIT and various other proteins, peptides, and consistent allelic losses. We know that p53 and the retinoblastoma gene are inactivated in over 90% of these patients, but they have not really led to specific molecular drugs. BCL2 can be overexpressed as well. There was a recent molecular analysis put forward by Dr. Charles Rudin and his group, dividing small cell lung cancer into classic neuroendocrine and variant neuroendocrine, and then there's a small percentage of people who have non-neuroendocrine. And these particular categories are associated with certain genes, such as the gene ASCL1 high, which is seen in the classic type of small cell lung cancer. There's the variant type, which we know from histology for a long time, which is associated with a different gene called NeuroD. This is neurogenic differentiation factor 1. And then there's YAP1 and another power 2F3 in these rare non-neuroendocrine forms of small cell. So basically, this has now possibly provided some kind of direction. We know that this type here, the NeuroD1 high in the variant, is driven by MEK, whereas the MEK-L gene is more important in the ASCL1 gene. And there may be certain targeted genes that can help to treat one type over another. So there might be some directionality in targeted molecular from that particular new type of analysis. Now, there has been lots and lots and lots of trials done that have been unsuccessful in systemic treatment, including interferons, merimostat vaccination, etc., that have not worked. More recently, there are a whole raft of drugs that have failed, including bevacizumab, an oncolytic virus called Seneca Valley virus, some types of PARP inhibitors, not all of them. I think it's still an open book for PARP. And particularly disappointing was an antibody drug conjugate called Rova-T, which has now been discontinued. Anti-PD-1 agents have not really been that successful, nor have anti-CTLA-4 agents. Ongoing trials of compounds of interest include PARP inhibitors, alisertinib, which is, as I said, in MEK high small cell lung cancer, may be quite effective. Various histone demethylase inhibitors, tropomyosin 2 antibody drug conjugates, these DNA repair drugs such as CHEK2, WEE1, ATR inhibitors, and so on. So there's a number of new drugs that are in trial. This is the rationale for PARP inhibitors. There's a high incidence of genomic instability and replication stress in small cell, which requires PARP for repair. And if you can block that with a PARP inhibitor, there's a lot of optimism that we'll be able to at least potentiate some of our standard drugs. One of the new drugs that's been approved is a drug called lurbinectedin, which works as a transcription inhibitor and also manipulates the immune microenvironment. This is a drug, the mechanism, there's the structure and the mechanism here with both a transcriptional effect that generates the single-strand breaks and the manipulation of the microenvironment. And this drug was approved by the FDA over the last year or two in relapsed small cell lung cancer. There's been a study ongoing with, so this is, by the way, this shows that it's active in a second line in a phase 2 study that led to the approval by the FDA with a reasonable efficacy response rate and duration of response. Unfortunately, the Atlantis study, which looked at the combination of lurbinectedin and doxorubicin, did not show any benefit in a recent randomized trial. although there was subgroups of people with long disease-free interval where there may be some benefit and some reduction in toxicity compared to standard of care. And this is just explained here, that the standard of care in second line was established in the 1990s, really, of topotecan versus cyclophosphamide, doxorubicin, and vincristine or CAV treatment, showing that this was, it didn't give you an increased survival, but there was a bit of an increase in progression-free survival and symptom control and a bit of lower toxicity. We don't like this particular drug, and we have been doing something else ever since I personally had an interest in retreating patients with exactly the same drugs that they had before, as long as it was 2 to 3 months difference. We found when I trained at the Marsden, 15 patients retreated with exactly the same regimen that they had before, whatever it was. There was a 67% response rate, and that was it was higher than that actually if they'd had a longer time off treatment. And there have been a couple of people who've tried the strategy of retreatment with the exact same chemotherapy that they've had before, now usually platinum etoposide. And as long as there's been more than a 2 to 3 month gap since the last administration of chemotherapy, there's a reasonable chance that patients will re-respond at least for a period of time. And so that's really what we do. And this was illustrated in this study here, where for second line platinum etoposide, that had platinum etoposide up front, that were randomized to carboplatin etoposide versus topotecan. And you can see that there's a big progression-free survival benefit for retreatment with platinum etoposide. And most of these patients were supported by GCSF, by the way, because you're retreating people at that point. But there was no difference in overall survival, probably because many of these people got third and fourth line treatments, but certainly a higher response rate and a longer progression-free survival for retreatment with platinum etoposide. But apart from that, there's really been marginal improvement in survival over the last 2 decades, and we're still stuck with the response rates of 60 to 80%, median PFS about 5 months, less than 10% of people are progression-free at 1 year, and these are extensive disease patients I'm talking about. The 2-year survival is less than 5%. So this is the rationale to think carefully in a different kind of way around the cancer immunity cycle, which I did show the day before yesterday. And just basically, there are antigens shed from these tumor cells that are turning over. These antigens are processed by dendritic cells. There's a checkpoint in the regional lymph node called CTLA-4 that can block the activation of the lymphocytes. But if they manage to get beyond that, they get into the circulation back to the tumor, where there's another checkpoint called the programmed death 1 on the T cell, and that will exhaust the T cell and frustrate the immune system. Now, you can block these checkpoints. You can block with an anti-CTLA-4 antibody, such as tremelimumab, and you can block the PD-1 axis by either at the PD-1 level or the PD-L1 level for the drugs such as durvalumab, for example. And therefore, there's a rationale to combine these two agents. But basically, we have felt for a long time that small cells should respond to immune therapy. It's associated with a very high tumor mutation burden. It's a high response rate to standard chemoradiation, which should explode the tumor and shed antigens prolifically. About 10% of these cancers have autoimmune diseases associated with them, paraneoplastic, and they do better. Actually, even though they're more sick from the autoimmune disease, they survive longer, indicating that the immune system has a role. And they're often, these tumors are often infiltrated with lymphocytes, and these people have a better response. But there are, there's no PD-L1 here in small cell lung cancer, very low PD-L1 expression, and high expression of LDH is probably associated with localized immune depression within the tumor. And a lot of these people get antibiotics, again, which is felt, on the way to diagnosis, which is felt to be not good with the microbiome and so on. So there's arguments for and against immunotherapy. Here's the very high tumor mutation burden. And here are the phase 3 studies of immune checkpoint inhibitors in first line. There's the atezolizumab, IMpower 133, plus etoposide platinum versus etoposide platinum, which was positive, and I'll show you that, and that's been approved by the FDA. Pembrolizumab was a kind of borderline active study, but this is not being pursued. Overall survival was felt to be statistically negative. And this study, the Caspian study, which I'll show, which was a 3-arm study of durvalumab and tremelimumab, or just a durvalumab with the chemotherapy versus the chemotherapy alone. And I'll show that in a minute. There have been second-line studies, all of which are negative, unfortunately, with nivolumab, 2 of them, and atezolizumab as well. Now, to get to the meat of this presentation, this is the Caspian trial. This was in treatment-naive, extensive disease, small cell lung cancer, reasonably good performance status, randomized into one of three arms in a 1:1:1 ratio, which, as I've said, is the durva plus tremelimumab and the topside platinum, or just the durva alone without the tremelimumab, or just the chemotherapy alone as the basis for comparison, the real control arm. After administration of the chemotherapy, with or without the immunotherapy, they could continue in arm 3 to optional PCI, but this was not allowed in either of the two immune therapy arms. But after the chemotherapy, you could continue on the durvalumab in each case on a Q4 weekly basis. And the primary endpoint was overall survival, with the secondary endpoints being the usual ones, including biological endpoints, for example, TMB correlation and so on. So these are the inclusion criteria: good performance status patients 0 or 1. They excluded people who had uncontrolled disease, active or autoimmune disease, any history of chest radiotherapy prior to systemic therapy, except palliative care outside the chest, and serious autoimmune paraneoplastic phenomena also excluded. These are reasonably good performance status patients. I will emphasize that. But I will say that this trial did allow the inclusion of brain metastases, including those that were untreated. And there were about 10 to 14% of patients on the study with brain metastases. And as long as they were not active, they could be included, whether they were treated or not. And that's a differentiator from the IMpower 133 study. There was to be 4 cycles of chemotherapy with the immune drugs, but you were allowed up to 6 cycles of chemotherapy if you had the topside platinum alone. And so what we have now is a 3-year updated overall survival. And this trial, by the way, is the longest update that we have for an immune study in this disease. And we see that at about 6 months, the curves split. They don't come together again. There's certainly a tail on the curve. The median survival here goes up from about 10.5 to about 12.9 months. The hazard ratio, which was 0.76, is now improved to 0.71, and the p-value is extremely positive at 0.003. And the median follow-up in these patients now is as long as more than 3 years. Now you can see here at 1 year, these curves are very, very separate, with an improvement of about 13%. And this continues for an improvement of about 8%, 9%. And out to 36 months, there's an improvement of about 12%. So there's about an extra 1 in 7, 1 in 8 people are alive out 3 years later as a result of the addition of durvalumab. So this is the durvalumab, where I'm not really going to be talking about the tremelimumab that didn't seem to be as good as this, but it's the durvalumab arm added to topside platinum. So you can see that in every single group here, there has been an improvement, by age, by sex, by performance status. All of these outcomes, these hazard ratios, are well to the left of the unity line, favoring the addition of durvalumab. And we see here that on the addition of durvalumab, there's more people alive, and more people are getting durvalumab by 1 year, and so on. So the majority of patients at 3 years remain on durvalumab at the data cutoff. In terms of side effects, we've talked about durvalumab before in the context of stage 3 non-small cell. There's not much to add here, except to say that the myelosuppression rates were actually a little bit less on the durva arm. AEs leading to death were about the same, whether you were on durva or not, or perhaps about 1% more. But it's, for the benefit you get, this is very worthwhile. So this updated overall survival analysis from this Caspian study is the longest median follow-up for a phase 3 trial for an anti-PD-1 or anti-PD-L1, and it demonstrated a sustained overall survival benefit with a well-tolerated safety profile. 3 times as many patients were estimated to be alive at 3 years compared to the chemotherapy alone if you added durvalumab. The progression-free survival was not that impressive, but you do see the additional number of people. There is this tail on the curve that shows that there is a benefit, but you certainly see it in terms of what really matters, which is the survival. You also see the benefit in terms of the enhanced response rate, going up by about 10% actually, which you do not see in the IMpower 133 study, by the way. And you see a better duration of response here. There's a considerable improvement in the duration of response. In terms of most of these patients did get subsequent anti-cancer therapy, and some people in the topside platinum arm were crossed over to immunotherapy, about 5% of them, but most of these people did get subsequent chemotherapy. So I don't think the explanation for this benefit does relate to differential exposure to second-line treatments. The safety summary, again, in the D plus E palm arm, AEs leading to death is the same between the topside platinum and whether durvalumab is there or not. So a really very safe drug, very, very little in the way of very serious adverse events that's any different or added from the chemotherapy alone. Most of these people did get colony stimulating factors, and some of them got blood transfusions, but actually fewer in the durvalumab arm. So there was actually less myelosuppression in the durvalumab arm. The side effect that we're concerned about, 2 side effects of interest, hypothyroidism, kind of mild. You do see a bit of hypothyroidism, so keep an eye on the TSH. And pneumonitis, very, very little actually, very little pneumonitis. So the pneumonitis that we've seen in other situations may be more related to the addition of radiation to the chest. This does not alter the pharmacokinetics of any of these chemotherapy drugs. And if we look at the PD-L1 expression, we see that most of these people actually have low PD-L1 expression, and there is really no association with PD-L1 expression. So we do not advocate the measurement of PD-L1 expression in small cell lung cancer. There's no place for it. In terms of the brain metastases, as I said, patients 10 to 14% with brain metastases were included in this trial, and those with brain metastases, but not that many, is about 30 in each arm, but they certainly have a numerical survival advantage of about 3.5 months with a decent hazard ratio. And you see, of course, the patients without brain metastases, as you would expect, about 13 versus about a 2.5 month increased survival. In terms of the quality of life, the baseline functioning was about the same. Patient-reported outcomes, this is the symptom scores, were about the same. And if you look here at the time to deterioration in these functional scales of cognitive functioning, global physical functioning, and so on, you can see it is all better for the addition of the durvalumab. And here is the time to deterioration of symptoms. And we place a lot of emphasis on this in terms of quality of life. We know these people are very symptomatic, and we see here that there's marked protection against symptomatic deterioration with the addition of durvalumab, as you can see in these curves here for global health status, physical functioning, cognitive functioning, and so on. TMB has not turned out to be a useful biomarker, interestingly. Patients deriving long-term benefit at 12 months, most of them are on the immune drugs compared to platinum chemotherapy alone. Overall survival in thoracic-only disease is better, for extrathoracic disease is better. So whatever parameter you look at. So just briefly, the Empower 133 trial was a similar study, but not identical. And this was also a first-line small cell extensive disease, a good performance status, randomized to carbo here. So there was no cisplatin, whereas in the previous study, you could allow either cisplatin or carboplatin. Here, it's only carboplatin on the top side with atezolizumab. And we do see a survival advantage, about 12.3 versus about a 2-month median survival. The hazard ratio here was 0.7. The PD-L1 expression did not really correlate very strongly one way or the other. This is the progression-free survival, which is, again, not very impressive. And in terms of the response rates, we see actually a slightly lower response rate, interestingly, for the atezolizumab, whereas in the durvalumab arm, there was a 10% improvement. Here, in fact, there's actually a 4% decrement in the response. Now, whether it's probably not a true difference, but due to the atezolizumab here, but you do not see this increase in response rate that you do see with the durvalumab. In terms of side effects, treatment-related side effects, I think it's a very acceptable drug. There's more rash, there's a bit more hepatitis, more infusion reactions, and so on. But both of these agents are relatively well tolerated. The survival in the key subgroups, again, is better across the board, with the exception here of brain metastases. And again, that might be another differentiator. The quality of life here really didn't show much difference in physical functioning and role between the atezolizumab group and the chemo alone group. Cognitive functioning, no difference. Emotional functioning, social functioning, perhaps a little bit better for a short period of time. Health-related quality of life, a little bit better, but probably not statistically significant. There was some improvement in dyspnea, but the rest of it is not particularly impressive, but there is some improvement in dyspnea. And here's the updated overall survival of the IMpower 133. Hazard ratio is deteriorated now to 0.76, and there's only a 2-month increase in median survival. This is the 3-year overall survival for the Derva study, the Caspian. This is the study that doesn't have as much long-term survival data, the IMpower 133. So we have more long-term data, and these curves do stay apart. There's a little bit of doubt as to whether these curves are staying apart in the atezolizumab study, but they are staying apart for a longer time in the durvalumab study. So there are a couple of differences just to finish off briefly between these studies. PCI was allowed in the control arm in both of these studies, but not in the experimental arm in Caspian. And untreated brain metastases were allowed in Caspian, but they were excluded from IMpower. So this really means, and by the way, you're allowed 6 cycles in the control arm, but that wasn't the case in IMpower. So the control arm was actually strengthened in the Caspian study. So it was harder bar for the durvalumab to climb, and it did so compared to the IMpower 133. So this is just a comparison of these studies, cis and carbo alone, number of cycles in the experimental arm, 6 in IMpower and only 4 in Caspian. And you see here the progression-free survival at 12 months is bigger on Caspian than IMpower 133. The duration of response is longer in Caspian than in IMpower 133 with atezolizumab. And the objective response rate improvement is much more with the durvalumab than it is with the atezolizumab. So on the basis of this data in Canada, we've decided to fund the durvalumab in this indication with the first-line small cell lung cancer because of these improvements look a bit better. PFS, for example, objective response rate, and the hazard ratio a little bit. So again, just in the interest of time, just to say that the quality of life data is somewhat better on the Caspian study for improvement in physical functioning, cognition, and time to deterioration. Although there are some improvements in the atezolizumab, it's not as obvious as it is with durvalumab. First-line treatments, maintenance treatments have failed with the PD-1 and the CTLA-4. NCCN now recognizes durvalumab as well as atezolizumab as options in first line with chemotherapy. Durvalumab seemed to be higher in efficiency and consistency in these so-called evidence blocks where they compared chemo alone or atezolizumab or durvalumab. And so basically, in conclusion, we have a strong benefit from the addition of durvalumab that is consistent and maintained. The FDA approved durvalumab more recently within the last year or so. And just to finish off, if I may, Mr. Chairman, just a quick case report, just a couple of slides. We have not been using this here for very long in Canada, so I don't have as much experience of this in small cell as I do in non-small cell. But here is a 72-year-old man with background COPD, well managed on Spiriva. He's a lifelong heavy smoker, has 4 days of increasing dyspnea and hoarseness, presents to emerge. Here's the lateral chest X-ray. You can see there's only one diaphragm. There's this kind of haziness, and there's what appears to be a large mass here on the lateral. And again, if we just look here at the PA film, you can see actually the one side is whited out almost completely. There's obvious collapse of this lung. This diaphragm is shifted up, and the mediastinum is starting to shift over. And there's a sense that there's a large paramediastinal mass there. So here's his CT scan confirming these findings, and he obviously has COPD in the contralateral lung as well. Here's the PET scan. There are the lymph nodes, and there is the primary tumor out there just next to the vertebra. So this gentleman has mediastinal supraclav lymphadenopathy. There's the supraclav node and a large proximal primary mass. And the rest of his body is clear, but we felt this was extensive disease. It was obviously into the pleura. So this really was not something that we could encompass in a curative intent radiation. So he had a bronchoscopic biopsy, and you see here the classical small cell features. This is the sheets of sort of monomorphic small cells. They stand with the pancytokeratin. There's a very high Ki67. There's a synaptophysin positivity, and the TTF1 positives. Very, very typical for small cell lung cancer. And he's treated now with palliative radiation because he's very short of breath. We're desperate to get this other lung expanded. And this is the radiation that we feel is treating most of the disease, but certainly not all of it. But we felt it might be enough. And I'm not a radiotherapist, but our talented radiotherapist felt this was enough to expand the lung. So he then saw me in medical oncology just as he finished his last fraction of radiation. He was starting to feel better. And we offered him chemotherapy with carboplatin etoposide and Durvalumab to start the following week. And by the end of the first cycle, when he's come for cycle 2, we can see this lung is now completely expanded. He's feeling much, much, much better. He's tolerating the Durvalumab very well. And our plan now is just to proceed through the Durvalumab, and he's now had 3 cycles of that. And our aim is just to keep going. And that, Mr. Chairman, is my presentation, and I thank you for your attention.
Thank you very much, Dr. Vincent, for this comprehensive, informative talk. And the floor is open now for questions.
May I ask a question, Doctor, please?
Please.
Yes, Dr. Ayman.
Thank you, Dr. Vincent, for this updated lecture. My question, if we started immunotherapy with chemotherapy as a first line, which is the best time for prophylactic cranial irradiation as the patient getting response? So what's the best time for radiation?
Well, we think it's after the end of the chemotherapy and in between the Durvalumab. So we think within a month or 2 after the chemotherapy, when the patient started to recover from the chemo. I think it's very important, if you're going to do PCI, to do at least a CT of the brain, and preferably an MR, just to make sure there isn't actually metastatic disease by then, because there could be in this disease. So I would say within a month or 2 or 3 after the end of chemotherapy, and maybe in between the Durvalumab treatments, you could consider. You might want to delay that. I wouldn't do it concurrent with the Durvalumab. I'd just do a little bit, in between the Durvalumabs, with a bit of time on either side.
Okay, thank you.
As I say, we don't have, the PCI was not permitted in the Durvalumab arm. Okay, and just on the trial, it was on the atezolizumab study. It was,
Yes.
but not that many people got it. But it was. So I just say in the PCI was permitted on the control arm in the Caspian study, but we didn't do it. So I'm not here to say it's perfectly safe, because we don't have that data. But if you want to do it, I would say just do it away from the Durvalumab.
So you don't recommend to go for BCI in the Dorva arm, or if we plan to use Dorva?
No, I don't have a strong recommendation for or against it. I'm not, I do notice that the PCI can improve survival rate in this disease.
Yes.
For extensive disease, but I think there's more of a need to do it in limited disease, with this. But I think it's something you can discuss with the patient, saying that we think it's probably safe with the Durvalumab, which we don't have a lot of data yet, and would seem to be safe with the atezolizumab, but only a small number of people actually got PCI, and some of them got headaches and dizziness. So there's a little bit of a question mark about, is it safe to combine this with this immune therapy of either type of immune therapy? So if you're going to do it, I think just talk to the patient about the risks and benefits, and just make sure the Durva is not concurrent with the Durvalumab, and just say that you're a little bit, there isn't a whole lot of data one way or the other. So I'm not for it or against it, but I do understand that some people might be interested in it.
Thank you, Dr. Vincent.
Any other question? Dr. Vincent, I have a question. Why do you think, in your opinion, why do you think that immunotherapy fails in second line and beyond?
I think these people are, very immunodepressed. So we know that if you do skin test, for T cell function, just like a, Candida antigen or, a TB antigen, that many of these people in the second line do not mount an immune response. You don't get the swelling and the redness that you should get. Everybody should be allergic to Candida. We're all exposed to Candida. So if you do Candida skin test, in a normal person, you should see a vigorous, lump and redness and swelling. These people, they don't, with, when they're, far into this disease with small cell lung cancer. And this work was done a very, very long time, 30 or 40 years ago, but not many people are aware of it. So I think these people are systemically immunosuppressed, actually. They're systemically immunosuppressed with bulk disease. And that's why I think their immune systems are just not in shape to actually benefit from it. And that's why if you use it earlier on, when there isn't so much bulk disease and so on, there's probably the immune systems are still reasonably decent shape. I think that's the reason.
Thank you. Do you have a question, Doctor? I think we have a question from our colleague, Doctor.
Thank you, sir. But I wonder, why there's no studies about combination of immunotherapy and chemotherapy in the treatment of limited stage small cell lung cancer?
Oh, it's coming. It's coming. I think it's the Adriatic study. So it's coming, and I think we should get the result quite soon. Yeah, it's definitely been done.
So if we don't have any further questions, I would like to thank Dr. Vincent for this excellent talk, and we are wishing to see you next year face to face, hopefully. And with that we conclude our session today.
Thank you, everybody, and keep safe. Thank you.
Good afternoon. Thank you for being here with us. In this evening session of bladder cancer, I'm Dr. Mohammed Obaidat, consultant medical oncologist and hematologist at Cancer Military Hospital at Royal Medical Service. I will be the moderator of this session. I'm pleased to welcome Dr. Mark Lynch, a consultant medical oncologist from UK. Dr. Mark Lynch, he is associate professor at University College of London Cancer Institute, where he leads the urological cancer biology group and honorary consultant medical oncologist. Dr. Lynch trained as medical oncology at the Royal Marsden Hospital, London. He continued his postdoctoral studies at London Research Institute, while also working as a consultant medical oncologist at Royal Marsden Hospital. His research is focused on the immune biology of these cancer with a view identifying the regional immunotherapy combination, predictive biomarkers, and novel liquid biopsy strategies. He is a chief investigator of a number of national and international combination immunotherapy trials in bladder and prostate cancer like Durance and Noptons. His talk will be about the immunotherapy in the management of bladder cancer. With this, I ask you to give you full attention to Dr. Lynch and help me in welcoming him to the stage. Dr. Mark Lynch, the mic is yours. Could you unmute yourself? Dr. Mark, we could not hear you.
Excuse me, could you please check your microphone, please?
No sound.
Maybe you have to give the computer permission to use your microphone, I think, once you got in.
Dr. Mark?
Could you please
sign in
again?
Sign out and sign in again.
Can you hear me now?
Yeah.
It's fine.
Perfect.
Thank you.
Okay, sorry. It default setting. Apologies for that. So, well, thank you very much for inviting me to come and speak today at this lovely conference. I had the pleasure of being with you 2 years ago. In fact, it was the last conference that I attended before COVID lockdown. I really hope we can get back to going to face-to-face conferences very, very soon. So I'm going to share the file. Can you see my slides?
Not yet.
Okay, so I may just need some help. So I press share.
Yeah.
And it's grant access system preferences. So open system preferences.
You can share it again.
Can you select your contents and start sharing?
Start. So where's the content? So normally we would just press share and it would.
Once you've pressed the share, you will find a block of some elements. Check one of these that you are looking for.
Says open system preferences. Is it possible to? I've sent them to you. Is it possible to download them your end?
Okay. Just a second. I think we've got your presentation. Just a second, please. Hold on.
Great.
Okay, thank you. Just let us, once you need the next slide, please.
So I'll go and then I'll instruct next slide, shall I? Okay,
right.
Apologies for that delay. So the title for today's talk says Immunotherapy for Bladder Cancer, and we're going to go through some recent updates. So next slide, please. So these are my disclosures. Next slide, please. Okay, so the aims of this talk, I'm going to give you a little overview of the bladder cancer staging, just to put into context the order of the content today. And actually, I'm going to start at the back end of the disease in terms of the advanced disease setting, second and third line advanced urothelial cancer. And then I'm going to move forward earlier in the disease as we go along. And that's partly because the new agents are first tested in this second and third line, and then the successful agents are brought earlier and earlier in the disease course to see if we get further benefit. So we'll talk about first line and first line maintenance. I'm then going to move into muscle invasive cancer briefly, non-muscle invasive bladder cancer, and then a little bit on biomarkers. So next slide, please. That's great. So this is the sort of standard staging diagram for non-muscle invasive bladder cancers, muscle invasive bladder cancers. That's the left part of the diagram. And then the right hand I'll come to in a moment. So this is the bladder cancer which has been opened out and laid flat on a table. The lumen is at the top of this diagram. And so the bladder cancers, they initially grow within the transitional cells at the top of the bladder within the lumen, and gradually they can go into the lamina propria. At that point, when they're in the lamina propria, they're still non-muscle invasive bladder cancers. As soon as they go into the muscle, the inner muscle, and then the outer muscle, that's a stage 2A and 2B disease. If it pokes through the bladder itself it becomes a T3 tumor, into surrounding organs is a T4 tumor. Then on the right hand, I've just got a diagram. This is actually a picture of one of my patients from last week who'd had an FDG PET scan. And what you can see here is a bone metastasis within the sternum. You can see a few little uptakes within the serosa within the bowel. So that's the metastatic disease on the right hand. We know that there's a male preponderance for this disease, 3-to-1. We know that tobacco is a causative. Non-muscle invasive bladder cancer is about 70% of the initial diagnosis of all bladder cancers. And this tends to recur frequently. So 50-70% will recur. Only 10-20% will actually progress on to a muscle invasive bladder cancer. The high risk non-muscle invasive bladder cancers are much more likely to go into a muscle invasive bladder cancer and to become a metastatic bladder cancer. And they have a limited survival in terms of an average of a 15-year survival. Muscle invasive bladder cancer has got a 50% 5-year survival. And once you're diagnosed with advanced disease, your life expectancy is just a little bit over 2 years. The next slide, please. So we're starting off with advanced disease here, and I'm going to talk about checkpoint inhibitors. So this is a really well-used slide. This is one of my previous colleagues, James Larkin, published this in the New England Journal of Medicine. This was in melanoma. This was really showing the benefit of checkpoint inhibitors and combination checkpoints. So this took melanoma, a disease which had a 9 to 12 month median survival, and you can see single agent ipilimumab suddenly puts out to a 40% are still alive at, or 34% still alive at 36 months. And then you add in ipilimumab and nivolumab, and you've got almost to a 60% and a flattening of the curve. So amazing results with checkpoint inhibitors. And then this was tried in bladder cancer. We go to the next slide, please. So there's a number of studies which have looked at checkpoint inhibitors in the context of bladder cancer, and this one is an example of first line in platinum ineligible. So the standard treatment for a newly diagnosed patient with metastatic castrate-resistant disease would be platinum-based chemotherapy. But there's a lot of patients that are not fit for platinum-based chemotherapy, previous renal dysfunction, or they've got peripheral neuropathy or poor performance status. And so some patients go straight on to checkpoint inhibitors. This was atezolizumab, and the response rates we saw in this trial of 20 to up to 30% were exciting, and the durable responses were notable. So this really prompted further investigation. Next slide, please. So this is one of the seminal papers. This is really the first randomized trial, and it's comparing atezolizumab versus physician choice of chemotherapy in second line. So these patients have all previously received a first-line platinum-based chemotherapy, and upon progression they get atezolizumab or physician's choice chemotherapy, which was paclitaxel, docetaxel, or vinflunine. And you can see on this graph there doesn't seem to be much air between both of these two curves. And this is partly because of the design of the study. It was designed to the primary endpoint was only to select patients who had PD-L1 positive disease. And so it just so happens that when we looked at this data, there was no difference in overall survival. Next slide, please. Great. But this was an exploratory endpoint, and this was actually the intention to treat population. So everybody who went into it, irrelevant of their or independent of their PD-L1 status. And this did show an overall survival benefit. The hazard ratio for survival was only 0.85, but it was statistically positive or statistically significant. And on the basis of this, we were able to prescribe atezolizumab in the second line setting. Okay, next slide, please. Similarly, pembrolizumab was tested, very, very similar trial designs of patients previously had platinum-based chemotherapy. When they progressed, they got either pembrolizumab or physician's choice of chemotherapy. And this one was the intention to treat group was up front. It wasn't predefined that it was only going to be PD-L1 positive patients. And actually, this became a positive trial from the get-go. The hazard ratio for survival was 0.73. And that was statistically significant. Looking at the subgroup analysis, all subgroups actually benefited, and liver disease positive and negative, or PD-L1 positive, yes or no. This is nivolumab, so it's just to show that all of the different PD-L1 or in this case PD-1 inhibitors are being tested in this area, and this is a phase 2 study, so it's a single-arm study. But similar kind of response rates were seen with nivolumab also. Next slide, please. So that kind of sets the scene in this second and third line setting. And the next thing to do for checkpoint inhibitors is to bring it further forward in the treatment paradigm. So we'll go there shortly. But before we do that, I'm going to talk about a couple of other developments in that second and third line setting. Next slide, please. So what we're going to do is antibody or antibody drug conjugates. Yeah, so we can move over. So the first one to discuss here is enfortumab vedotin. And so this is an antibody. So I've called this an immunotherapy because it's using an antibody as its targeting mode of action. But of course, it's also linked to a payload. And I heard in an earlier talk very similar. So this is MMAE as the payload. So that's a microtubule disrupting drug. And what happens is the drug binds to Nectin-4 in this case. Nectin-4 is pretty ubiquitously expressed on the surface of bladder cancers. It's differentially expressed in cancer versus normal tissue. So the antibody binds to the cancer cell. It's internalized into the cell where it goes into lysosomes, it's cleaved, and the microtubule destabilizer is released. There's also cellular disruption, apoptosis, but also the drug then spreads around into the surrounding tissue. And next slide, please. And so in a third line setting where we had never seen a positive trial, suddenly we have this result here, which shows a 44% overall response rate to enfortumab vedotin. So it's a single agent as a third line setting, but this is a real game changer. Suddenly we have an active agent in this area. Next slide, please. So the phase 3 study was then devised. And so this is a very similar design to those other studies that we discussed of checkpoint inhibitor. Here, what they're looking at is enfortumab vedotin. So this is given as a dose of 1.25 milligrams per kilogram. It's given on day 1, 8, and 15 of a 4-weekly schedule, and it's compared to the standard of care chemotherapy, docetaxel, paclitaxel, and vinflunine. Patients they had to have had previous chemotherapy, and they had to have had a previous IO agent. The primary endpoint for the study was overall survival. Next slide, please. And as you can see, the curves here are separating out. The enfortumab vedotin curve is the blue line on top here. The hazard ratio for overall survival is 0.7, which is statistically significant. And we're almost getting to a 3-month overall survival in this cohort. So this is this is potentially a practice-changing result. The reason to put potential there is these are expensive drugs. And so whether we're going to get authorization for reimbursement is another question. Next slide. Looking at the toxicity profile of this drug, it's actually really well tolerated. The things that we're typically seeing and of concern for the patients is some peripheral neuropathy and rash and pruritus, itchy skin. Next slide. Okay, so now I'm going to move to first line setting, and we'll also talk about first line maintenance. So next slide. So this is a combination, just a comparator slide of 2 slightly older studies now. So this is the Keynote 052, which is using Pembrolizumab, and Invigor 210 using atezolizumab. Now these are both first line, but again in those cisplatin ineligible patients. So you can see there are a few differences. Keynote has got 370 patients compared to 119 in the atezolizumab study. Similar kind of age, a little bit more visceral disease for the Keynote study, a little bit worse performance status in the Keynote study. But overall, the outcomes are reasonably similar, and we can see the overall survival is a little bit worse in the Keynote, which may reflect the slightly worse group that was going into the study. But the actual response rate, 29 versus 24, is pretty similar. Okay, next slide, please. So this led to a number of first-line studies, and the question was, should we be combining it with standard of care? So we've talked about the standard of care in the first-line setting is platinum-based chemotherapy. Probably the most widely used combination is gemcitabine plus a platinum. And so there's a number of these different studies which have been set up, mostly quite similar designs. For illustration purposes today, I'm just going to talk about the Invigor study. So there's 3 arms, A, B, and C. Arm A is the combination of standard of care plus atezolizumab. Arm B is atezolizumab, and arm C is standard of care plus placebo, so the standard of care. Very early on in the recruitment, or at least at the interim toxicity analysis, it was found that patients who were PD-L1 negative were getting an inferior outcomes to patients who were getting chemotherapy. So we stopped recruiting to the PD-L1 negative group for the monotherapy immunotherapy. So what I'm going to show you here is just the data from arms A and C. So this is gemcitabine platinum plus atezolizumab versus the control of chemotherapy alone. Next slide, please. And you can see that the characteristics for the patients are reasonably well balanced throughout. Next slide, please. Next slide. Okay, and so this was the intention to treat progression-free survival, and there was a difference in the progression-free survival of 0.82, so potentially promising. Next slide. That's showing this, but this is the overall survival here, and you can see that the overall survival, the actual confidence intervals here, there's a hazard ratio of 0.83, but the hazard ratio hits the 1 barrier, and although the p-value is quoted as 0.027, that is a one-sided, and it didn't actually meet the pre-specified statistical analysis. So this was deemed as a negative study for overall survival. So the combination of chemotherapy plus atezolizumab in the frontline setting, that first-line metastatic disease, isn't positive in the study. And the other 2 studies, both the Pembro study and the Durvalumab study, have also reported negative outcomes of combination therapy in that first-line setting. Next slide, please. And that negative result seems to be pretty consistent through all of the subgroups here. There's a slight suggestion that if you use cisplatin rather than carboplatin, you may have a better outcome to the combination of chemotherapy plus immunotherapy, but it's relatively small numbers. Okay, next slide. We can move on from here. It's a repeat of the previous slide. And this is a response rate, but I think we'll move on to the next slide. Okay, and now just looking at the toxicities that you get in the combination chemotherapy plus immunotherapy, very much like previous speaker was doing for small cell lung cancer. It's what we would expect. The things that really seem to be up a little bit is that there's increased rash, there's some slight increase in hepatitis, and there is an increase in hypothyroidism. Next slide, please. So now I'm going to move on to the first-line maintenance. So that is, instead of giving it concomitant with the chemotherapy, you give the immunotherapy sequentially, so after the cisplatin. And this is what has, the results of this are going to be practice changing. So the first one is the Pembro study. So it's HCRN GU14182. So it's Pembrolizumab versus placebo. So patients were allowed up to 8 cycles of cisplatin-containing chemotherapy. They had to have had metastatic urothelial carcinoma, and they were randomized 1-to-1 to the Pembro or the placebo. The Javelin study is using avelumab. So they used, in this particular study, there's between 4 and 6 cycles of platinum were permitted. So slightly less platinum were permitted. You could have carboplatin. It didn't have to be cisplatin. You're allowed 4 to 10 weeks between finishing your platinum chemotherapy and starting the avelumab. And again, it was randomized 1-to-1. This was a much bigger study, 700 patients compared to the only 107 patients in the Pembro study. Okay, and so we move to the next slide. So these are the characteristics in the Pembro study, and the groups are pretty well matched between the two sides. Next slide, please. And this is the kind of key thing, is the overall response here was higher in the pembrolizumab, so it's 22% compared to the 12%. And these were partial responses, but there was 9 complete responses in the pembrolizumab arm. Go to the next slide, please. And this is the slightly controversial Kaplan-Meier curve that was presented. And the reason it's controversial is that in order to discuss, instead of talking about hazard ratios and the statistical testing, they used a maximum efficiency robust test and got a p-value of 0.036. Essentially what this particular kind of statistical testing did is it edits out the first 3 months of this curve. And so if they look at the hazard ratio from the 3-month time point, then this is statistically significant and different. However, if you include that overlapping first 3 months, then this is not statistically different. So really, we should consider this, or many of us will consider this as a negative study. Next slide, please. The Javelin 100, however, is certainly positive. And this is the overall survival curve here. So the avelumab plus the best supportive care is in blue at the top compared to the red at the bottom. And if you look at the median overall survival, it goes from 14.3 to 21.4. So that's an addition of 7.1 months overall survival. So this is transformational in this disease. The hazard ratio is 0.69 and it's statistically significant. Next slide, please. And this is just looking at the PD-L1 positive. So if you do look at the PD-L1 positive group, particularly, the hazard ratio is even better. It's 0.56. Next slide. And let's move to the next slide. So this slide here is the progression-free survival, and again, that's highly positive. Now, toxicity, we will go to the next slide. That's good. Thank you. So the toxicities, again, very similar to what we expect with immunotherapy. It doesn't look as though having had the preceding chemotherapy is exacerbating any of the toxicities. The treatment-associated effects of avelumab occurred in 11.9% of patients, and there was a death in 2 patients in the avelumab arm. One was due to a sepsis and one was due to ischemic stroke. But notice the stroke was 100 days after a single dose of avelumab, so it's unlikely that would be associated. Next slide, please. So this is a summary from ASCO 2020 from Elizabeth Plymouth, and I just want to include that because I think it was quite a nice summary. And so this was really looking at what the best sequences of the current approaches being used in the first-line metastatic setting are, and should we use it? Is it really better to give upfront immunotherapy as a maintenance strategy, or would we still see benefit if we do it sequentially and wait for a second-line treatment? And I think it's nicely reflected at her guesstimates here. If you look at the top thing in the red box, we have 2 to 5 months on your chemotherapy at the beginning, and then the result of that of the avelumab study is a 21.4 month survival benefit. So you add them together and you get up to maybe about 25 months. If you compared that to sort of standard first line and then moving on upon progression with the studies, you're certainly well below the 20 month mark. So this really does seem to be a game changer. We are improving our patient outcomes with limited toxicity, and we're certainly trying to move over to this as a standard of care in the UK. Now, NICE have actually, in the first round, have rejected this, but upon appeal, it looks as though that they will probably review and accept this in view of the excellent prolongation of overall survival. Next slide, please. Okay, so this is another study in the first-line setting, and what this is using the really exciting results on enfortumab vedotin, the antibody drug conjugate that we discussed and have been shown to be efficacious in a second or third line setting. And what they've done is they've brought it forward to a first line setting, again in that cisplatin ineligible population, and combined it with pembrolizumab. And the main endpoint for this, because it's a phase 1 study, was safety and tolerability, but also looking at progression-free survival, overall survival. Next slide, please. And this is a truly remarkable slide, in my opinion. This is first-line patients, but you can see that the combination of enfortumab vedotin plus pembrolizumab has got an overall confirmed response rate of 73.3%. And so that's more than a 30% shrinkage of the evaluable disease. Median duration of the response was 25.6 months. And the 24-month overall survival was 56.3%. So this needs to be tested in randomized studies, and that is underway at the moment. Okay, next slide. And toxicity-wise, so it's quite similar to what we saw and we described in the second or third line. Mainly, there's a bit more fatigue than in the second or third line, as we would expect. But there's the alopecia, peripheral neuropathy, diarrhea becomes more prevalent in this slightly earlier stage. The rash is still there and pruritus is still there. Okay, next slide, please. So we're going to move to muscle invasive cancer now. So we're going to talk about neoadjuvant and adjuvant. So this is an example of a neoadjuvant study, as one that I was involved with. So this is the Abacus study. So this was 2 cycles of atezolizumab prior to going for curative surgery in the context of patients that have got muscle invasive disease. You can see the eligibility to that was T2 to T4A. They had to be node negative. They had to have transitional cell histology, and they needed to be fit for cystectomy. So the endpoint was the pathological complete response. Now we know that chemotherapy leads to pathological complete response in about 36 to 43%, that kind of ballpark. But these patients were again the platinum ineligible patients. They weren't fit for chemotherapy. So secondary endpoints were safety and radiological response. Next slide. And so in a nutshell, if we looked at the response rates, we have a PD-L1 positive group. They had a response rate of 37%, the PD-L1 negative group about 25%. And so we're seeing quite robust response rates, pretty similar to what you would expect with chemotherapy, but just with 2 cycles of atezolizumab. And so this approach is also being tested now in a number of trials in a neoadjuvant setting. Next slide, please. So again, using the enfortumab vedotin and doing the same methodology, taking our most active agents and trying to bring it forward. This one is being used in a neoadjuvant setting as well. And so a similar kind of groups. It's a cisplatin ineligible group. In fact, it's exactly the same as the Abacus criteria, T2 to T4A, N0 patients. They had to have predominant urothelial carcinoma. They had to be medically fit. And so patients then receive slightly different schedule to what they received in the advanced disease setting. This is given on a 3-weekly basis rather than a 4-weekly basis, and they only get it on days 1 and day 8, so they have a bit more of a gap. They undergo the radical cystectomy and then follow up. We have a look at the next slide, please. And just to look at the patient cohort, this is very typical of what we'd expect. 60, so nearly 70% were T2 disease, and approaching 30% were T3 disease, so just poking out of the bladder wall. If we look at the result here, This is the pathological complete response rate. This was 36%, and 50% of patients got pathological downstaging. Out of the 22 patients enrolled in this study, 19 received all three cycles. So we think it's pretty well tolerated. And very importantly, it didn't lead to any times in any delay in the time to surgery. Next slide. Toxicity-wise, again, very similar to what we've described previously, although it says increased dysgeusia here, so the change in taste for these patients. There were 3 patients who died as a result of, or died while on this study. And so that's 3 out of 22, which seems very high, but Dan Petrolak went to some pains during ASCO last week to explain the causes of these deaths. One was an acute kidney injury not considered to be related to the trial medication. It was thought to be due to the cystectomy. Cardiac arrest, also related to the cystectomy, and a pulmonary embolism, also related to the cystectomy. Next slide. So the MVIGA 010 or 010 study. So this is looking at patients who've got this is in the adjuvant setting. So the previous ones we've just been talking about doing it before surgery, but this is talking about giving it to patients after they've had surgery for their muscle invasive disease. Patients could be eligible if they'd had neoadjuvant chemotherapy. So that's the Y here, meaning they've had treatment. So the YPT2, if they've had chemotherapy, they had to be T2 to T4 or node positive. If they hadn't had any chemotherapy, it had to be T3 to T4 node positive. Patients got their atezolizumab or went into observation. So it wasn't a controlled trial, it was an observation group, and disease-free survival investigator assessed was the primary endpoint. We look at the next slide, please. So there wasn't any difference here in the primary endpoint, which is disease-free survival. And so the hazard ratio here is 0.89. The secondary endpoint for this study is overall survival. The hazard ratio was 0.85, but the confidence intervals crosses 1. So this was not a statistically significant study, which was disappointing. So a further exploratory analysis was done, and actually that's where the real interest comes. That's the next slide. It'll be 2 slides time, but the benefit, there was no benefit in any of the groups, and importantly from this slide, although it's quite small, you probably can't see it, just want to say that the PD-L1 positive group didn't seek any or didn't gain any benefit from this adjuvant atezolizumab. Okay, the next slide, please. Okay, so this is the really interesting slide from my perspective. What was done as a prospective plan for the study and an exploratory endpoint for the study was to see whether or not ctDNA determination could predict responders versus non-responders. And I think what I'll get you to do is focus just on this right-hand graph. The light red and the light blue at the top here are the patients who are ctDNA negative. So this was taken after the cystectomy. And in those patients who are ctDNA, they have, as you would expect, I guess, they have a better outcome. But importantly, there is no difference whether or not they received atezolizumab. So they did not benefit from the atezolizumab. In the patients who are ctDNA positive post-cystectomy, there is a clear benefit now for patients who are treated with atezolizumab, and the hazard ratio for survival on this right-hand graph is 0.59. So we now have a molecular determinant for benefit from atezolizumab in the adjuvant setting. Next slide, please. So non-muscle invasive bladder cancer. So next slide. So non-muscle invasive bladder cancer has been the stalwart for, and really a beacon for immunotherapy for all of solid tumor oncology. BCG has been a successful therapy for a long time. As I discussed at the beginning, the real problem with non-muscle invasive bladder cancer is it keeps relapsing and remitting, and then there is a risk in terms of the high-risk patient group of it going on to become muscle invasive disease or even metastatic disease. So the idea is taking those the group of patients who have failed BCG and testing to see whether, instead of going on to what is standard of care, a cystectomy, because that has significant morbidity, it has problems for patients' comorbidities. Instead of having the cystectomy, could you have Pembrolizumab immunotherapy? And so patients went on to receive the Pembrolizumab for up to 2 years. And next slide, please. This is the first cohort, which is the papillary cohort. And the notable thing here is that there was deemed to be a complete response rate in 40% of patients. If you look at the responders, the duration of response was 12.7 months. And I haven't put it on this slide here, but the updated review, which is in 2021, looked at what the 12-month disease progression-free survival was, and that's 83%. So 83% of patients were free of progression at that 1-year mark. And normally you would expect only 35 to 40% maximum to be free at that time. So the immunotherapy is seeming to have a benefit. We'll get the next slide. So the question is, what can we do next? Is there anything else we can do to improve that? And that's where we come to combination therapy. So this is something that I'm doing with the team in the UK at UCL. So we've looked with Shionogi, which a Japanese pharmaceutical company with an expertise in vaccines, at looking to make a vaccine against a number of tumor-associated antigens that we find in non-muscle invasive bladder cancer. So these are some of those antigens that we've seen. And what we're showing here is the uptake. They've got controls on the left, and we've got the non-muscle invasive bladder cancer tissue on the right with significant uptake. And we've got a peptide vaccine against all of these antigens, and in fact 2 other antigens also. So it's a 5-peptide antigen, a 5-peptide vaccine. Next slide, please. And this is the design. In fact, this study formally opened yesterday in the UK. So excited it's just opened. But what we're going to do is patients who have progressed, were refractory or resistant to BCG therapy will now get 6 months worth of Durvalumab, which is delivered monthly. And then they will get a vaccine, which is delivered subcutaneously in the proximity of lymph node regions. And that's given initially weekly for the first half, and then it's given 2 weekly thereafter. Next slide. How much longer have I got? I'll keep going for a bit. So I just want to show just some of the biomarkers of immunotherapy that seem to be relevant. So those tumor mutation burden and neoepitopes, like other tumor types such as lung and melanoma, these factors seem to predict response to immunotherapy. Could you press the next slide, please? Okay, so we know that bladder cancer has got quite a high mutational burden, and so that's what this red line on the top left-hand graph shows that. And we also know that response is related to the mutational burden, and we'll go to the next slide.
But Dr. Mark, we have 2 minutes extra.
Okay, great. Okay, so we also know that there's perhaps inflammatory infiltrate can predict response, and that's been shown mainly through transcriptomic profiles. But here is just showing the dense inflammatory infiltrate that we find in some bladder cancers. Okay, next slide. This is showing the transcriptional profiles, and you can see this dark red one here on the right is the patients that got a complete response or a partial response, and on average they have a slightly higher CD8 infiltration. Next slide. There are also other transcriptomic signatures which have been identified to predict response to the immunotherapy. For example, the TGF-beta transcriptional signature. And if you have this transcriptional signature, you are likely to do worse. If it's the 4th quartile is the high expression, which is this red line. So the Kaplan-Meier shows that the survival is worse if you have TGF-beta and you're treated with an immunotherapy drug. Okay, if we can get think, well, I'll skip this next bit and I'll just go to the conclusion slides. So if you can forward a little bit, and again, and again. Okay, actually, if you go back one, I'll just talk back one again. So one of the things that we've been doing is we've been collecting the lymphocytes within the urine, and we found that if you look at the lymphocytes in the urine in patients who've got bladder cancer, you can actually, it's a surrogate marker for the tumor infiltrating lymphocytes within the bladder, and this shows some of the checkpoint markers by flow cytometry. What I want you to take away, if you look on the treatment naive on the left, the urine and the tumor have got very similar expression of these checkpoint molecules, whereas the non-tumor and the PBMCs, the peripheral blood, have very different profiles. So we think the urine lymphocytes will help us monitor what's going on in the tumor in terms of their checkpoint expression, and that could help define treatments in the future. Okay, we'll go forward, and again, and again. So I just come to the conclusions. So the things I want you to take away from this meeting. So enfortumab vedotin and other antibody drug conjugates represent the next step change in urothelial carcinoma. Maintenance immunotherapy prolongs survival and will become a new standard of care. Biomarkers can enrich for patients that are going to benefit from immunotherapy. Bringing treatments forward in the disease spectrum is likely to improve outcomes, and novel combinations and patient selection is needed. Okay, and next slide. Just want some acknowledged colleagues that I work with, and I'm going to finish there, and very happy to answer any questions.
Thank you, Dr. Mark, for this wonderful presentation. And if anyone have any question?
I have one question.
تفضل يا دكتور.
Thank you for this excellent presentation. I have actually a general questions about the immune checkpoints inhibitors.
Okay.
I think the difference between PD-1 versus PD-L1 inhibitors result in different efficacy of the drugs. For example, in your presentation, in the first line setting, Atezo give, I think, overall survival 40 months versus 30 months for the Pembro, more with the Pembro. This is from the different PD-1 versus PD-L1 inhibitors effect?
So I don't really know the answer to that. So what we usually answer to that question is that there's probably differences between the patient characteristics and patient selection going into the study. And there are some very subtle differences of the patients going into the study. When we showed so for example, we showed you that the Pembrolizumab in that second line setting, in the first line setting of cisplatin ineligible patients, it looked as though the survival was slightly longer in Pembrolizumab compared to atezolizumab. However, the actual hazard ratio was very, very similar in those two groups. So, and what we also showed was that they had more patients with liver disease and more patients with poor performance status. So I think that probably is representative of differences in patient characteristics rather than the drugs themselves. When we looked at in the second line setting where atezolizumab the trial didn't show a statistically significant overall survival difference in their planned analysis, I think it's probably because of a difference in the trial design. The trial design had a lot of merit. The preliminary data had already shown that you were probably more likely to respond if you had PD-L1 positive disease. So looking at that group first seemed to make a lot of sense. However, it just so happened that if you look in the control arm, there were 3 drugs that the physicians could choose, which was docetaxel, paclitaxel, or vinflunine. It looks as though the patients who got vinflunine in the control arm, who were PD-L1 positive, had an exceptional response to the chemotherapy, something we didn't know before. And so that's probably led to the negative study for the atezolizumab second line study. One further thing is in the lab, one of my colleagues at UCL has tried to make hybrids of the the drugs. So mixing part of one antibody with another part of another antibody. And when we mix and match that in mouse studies, so lots of caveats here because it's not quite the same sequence, but when you mix and match in mouse studies, they seem to have very similar efficacy. So I don't think it's the drug itself.
Another question regarding what you mentioned, the maintenance therapy for Pembro for 2 years. Do you think this is cost effective? Any cost effective analysis on this trial?
Okay, so actually the trial didn't continue for 2 years for the talking about the avalumab one, or for the maintenance one. So
The maintenance one. I think
okay.
24 months or 24 doses.
Oh yeah, so that was the avalumab one. So the avalumab one, sorry, that was the atezolizumab study, which had a 2-year stopping rule, and so that's not going forward in the context of an all-comer trial because overall it was negative. It was only when we looked at the circulating free DNA that we have a positive result there. However, the avalumab study, which is the Pfizer Merck drug, that had the 7.1 month overall survival benefit, and that trial didn't have a 2-year stopping room. It was continuous. When we did the assessment, the cost effectiveness assessment with NICE, they deemed it to not be cost effective, and they deemed it not to be cost effective. I don't think I'm breaking any confidence saying this because it's in the public domain. They deemed it to be not cost effective because they said 2 things. It didn't reach the end of life stopping rule that NICE have. So if you've got an anticipated overall survival of less than 2 years, the value of the reimbursement is higher than if it's not less than 2 years. And because the outcomes in the patients were good in the trial, it went into the lower remuneration group. That was one thing. And the second thing is they hadn't considered a stopping rule by NICE, and NICE have now said they will consider a stopping rule. And so we're hoping that will make it cost effective.
Thank you, Dr. Lynch. With this, I will end this session, and we hope to see you next meetings by face-to-face. And thank you for all audience.
Great. Well, thank you for the invite and enjoy the rest of your meeting.
Thank you.
Can we start? Okay, assalamu alaikum. Good afternoon, everybody. It's my pleasure to introduce our next speaker, Professor Enrique Grandi. Professor Grandi is the director of the Medical Oncology Program and Clinical Research led at the MD Anderson Cancer Center in Madrid. Dr. Grandi is focused on the research on genitourinary and endocrine tumor and take active collaboration in the development of the translational research and early drug development unit. He was awarded his PhD for pharmacokinetic and pharmacodynamic study of tyrosine kinase inhibitors in liver metabolism, and he holds master's degree in the molecular biology of cancer from the Spanish National Cancer Research Center. He published more than 200 manuscripts in peer-reviewed journals, and he also the founder of the Spanish group of research on orphan and uncommon tumors. Professor Grandi is editor of several international journals and has participated in the most recent trials in the field of the bladder cancer that led to the approval of the new drug. And he have now available and chairs the steering committee of the MVigor 130 trial, which we discussed before in the bladder cancer. Professor Grandi today will be updating us about the recent advances in the treatment of renal cell carcinoma. So, Professor Grandi, you are welcome, and the floor is yours.
Thank you so much for the kind invitation. Thank you so much for the kind introduction, Dr. Fauci. I want to really, I'm very grateful for receiving this invitation from the Jordanian Society of Hematology because, I'm proud of being here with you, although virtually. Hopefully, inshallah, next year we will be able to join physically all together. And I want to also thank Pfizer for sponsoring this initiative. This is my task today to talk about the recent advances in the field of renal cell carcinoma. And we have a lot of good news for our patients in the last decade. In the last decade, we have seen that, we have changed dramatically how we are facing, how we are approaching to our patients with metastatic renal cell carcinoma. These are all my disclosures, and I'm very happy and I'm proud of having worked with all the companies who have developed any drug in the field that are approved in the field of RCC recently. So at the end, I don't have that much disclosures to say. And this is a disclaimer from Pfizer. And in RCC, kidney cancer, renal cell carcinoma, can we consider this is a single entity or we have many different entities inside of one tumor? Well, take a look at how dramatically different are from the histology and from the molecular perspective, the patients that we are facing in the clinic. Nothing to do the type of cells from clear cell to non-clear cell histologies. But inside of these tumors, nothing to do the molecular behavior, the molecular characteristics of one patient versus another one. Why I'm bringing this slide here? I'm bringing this slide to realize that we need to know in front of which patient we are, how our systemic treatment options should be completely different depending on how is the molecular driver of our patients or what is the type of cell driving the tumor growth in our patients. This is our task, this is our duty, this is our role that we will definitely need to face in the future. Angiogenesis is the key molecular driver of the tumor growth and tumor development of our patients with renal cell carcinoma. More than 90% of the patients, at least with clear cell histologies, will be harboring molecular alterations that at the end are conditioning for the creation, the development of blood vessels that are supplying for oxygen and nutrients to our tumors. The molecular drivers, the angiogenesis, have driven to the development of different drugs, the tyrosine kinase inhibitors, that are considered the backbone treatment for the systemic approach of our patients with metastatic renal cell carcinoma. During the last decade, we have seen as a broad range of different tyrosine kinase inhibitors have been approved in this field and have been provided for progression-free survival increase and significant response rate increase to our patients with metastatic renal cell carcinoma. New drugs have been developed in this field as well, including belzutifan, an hypoxia-inducible factor inhibitor. So it means that angiogenesis has not ended up here. Angiogenesis is still a fashion drug to target our patients in renal cell carcinoma. However, as I mentioned before, there are many new drugs that are coming that have been added to the armamentarium that we have to treat our patients with metastatic renal cell carcinoma. Particularly immuno-oncology checkpoint inhibitors have been added either in combination or adding to tyrosine kinase inhibitor in this field, changing the landscape. Now, this new combination based on immunotherapy has replaced single-agent TKI in the major clinical guidelines. But I think there is still room to treat our patients with single-agent tyrosine kinase inhibitors, besides the access issues that we can have in our respective countries. Which is the best treatment option we can offer to our patients with metastatic renal cell carcinoma? Well, these treatment options are conditioned by the environment of where we are treating our patients. Access is an issue. Access to novel medications, access to novel drugs is an issue. I don't know in your country, in Jordan, but in my country, in Spain, today, after 3 or 4 years since nivolumab, ipilimumab was approved, this is the only combination based on immunotherapy that this is reimbursed for our public patients with renal cell carcinoma. No single combination of TKI plus immuno-oncology drug has already been approved in my country, and we cannot therefore offer out of a clinical trial to our patients. So TKI are still the backbone treatment to our patients in daily practice, at least in a country like Spain. Active surveillance can be considered an option. Well, maybe some patients can benefit from active surveillance, but this is not the topic today to talk. Let's think about this clinical case. This is a real clinical case of a lady with 57 years old with no relevant comorbidities, and take a look at the small lung metastasis from a renal cell carcinoma that was removed a couple of years after. ECOG performance status is 0. This patient has a favorable risk prognosis according to Hens criteria. So this is the ideal patients that we want to treat in the practice. You can say, okay, we can probably try to go for surgery and to remove these micronodules. Unfortunately, this patient had other several small micronodules, less than 3 millimeters in both lungs. So unfortunately, no direct surgery could be performed on this patient. So this is a patient with very small volume of the disease, with a clear cell renal cell carcinoma, with a favorable risk according to Hens criteria. So think about what would you offer if you are treating these patients in your clinic. You can go for active surveillance, why not? You can go for single agent TKI, I will try to convince about it, or you can go for doublets of immuno-oncology or combination of TKI plus immuno-oncology drug. But do you think these kind of patients really deserve, really merit for such an aggressive approach from the beginning? Let's try to use the common sense. This is the Hens criteria. You have seen this graph many times, and this is the difference in between the overall survival that you can expect in your patients with favorable risk versus intermediate versus poor risk. If you believe on the Hens criteria, and you need to believe that ECOG performance status and time from the initial nephrectomy, anemia, hypercalcemia, neutrophilia, and thrombocytosis are the best tools that we can use to select one or other alternative to our patients, that's fine for you. Personally, I'm concerned. I don't really like to treat my patients today in 2022 based on the neutrophils levels, or based on the hemoglobin of the patient, or even based on the platelets levels of the patients, on when the nephrectomy was performed. I want to use the common sense. I want to use the clinical feeling, the gut feeling that I have when I'm treating a patient in front of me. In a patient like this that I described before, 57 years old, no comorbidities, small micronodules in the lungs, well, I think this is a real favorable risk patient. And if I believe that this is a real favorable risk patient, well, probably I need to think in long term when thinking about it. I need to think that I probably will need for subsequent lines of treatment. I don't only need to think about what I am offering now to this patient, because probably these patients will need for 2, 3, or even 4 lines of systemic treatment. So probably active surveillance is an option, and probably tyrosine kinase inhibitors are an option here. However, for those patients with a purer prognosis, those patients with more aggressive tumors, well, I am not thinking in a long term. I am just thinking in a short term, trying to offer him something that can make a tumor shrinkage, trying to get a tumor control, or trying to diminish the symptoms of the patients because of the size, because of the volume of the tumor. So the goals, the clinical objectives that I have in my patients can completely vary from one to another patient. And this is what I'm calling the common sense. So I think there are some patients that still today, regardless the access that we have or not to novel combination based on immunotherapy, I think there are patients today that are meriting to receiving tyrosine kinase inhibitor as single agent in the first-line setting. Take a look at this data coming from the real-world perspective with sunitinib, given according to the labyrinth, 50 milligrams, 4 weeks on, 2 weeks off, in the real practice. This is the results of the Adonis trial led by Dr. Smidinger. And take a look at how we can expect completely different outcomes with sunitinib depending on the numbers of adverse prognostic factors by HEM. But these data are coming from the clinic. Take a look at the overall survival of those patients treated with sunitinib with favorable risk, more than or almost 100 months. So this is about 8 years. But take a look at the median progression-free survival, 23 months, almost 2 years of median progression-free survival if we are able to select clinically those patients that can be benefiting from sunitinib. And if we do one thing, very easy thing, we put together those patients with 0 or only 1 adverse prognostic factors by HEM, take a look at how dramatically these graphs for progression-free and overall survival are separated. So it means that very easily in the clinic, we can really select who will be the patients who will benefit more from receiving single treatment with a TKI, particularly sunitinib. So these data are something that you can really use in your daily practice. These data can really be translated easily to treat your patients in the daily practice. I think sunitinib, this is a very good drug. What about the molecular biology? Is there any relationship in between the clinical outcome and the molecular biology behind? I think so. These are the results of the angiogenesis expression, the levels of angiogenesis gene signatures that we have in our patients. And those patients with favorable risk, up to 74% of them, they are harboring positive immune and angiogenesis gene-related expressions. So it means that there is a very strong molecular rationale behind the use of TKI, single agent TKI in our patients, particularly those patients with favorable risk. Take a look at this graph because I think this graph is not very well known from the CheckMate 214 trial. I remember the CheckMate 214 trial was the phase 3 trial that compared nivolumab, ipilimumab versus sunitinib. And always that we are referring to this trial, we are always referring to the intermediate poor risk population in which nivolumab, ipilimumab is doing much better than sunitinib. And this is great. However, this graph is coming from the favorable risk subgroup of patients. And as you can easily see here, sunitinib in this trial did it much better than immunotherapy. The median progression-free survival was almost 20 months versus 14 months. Clinically significant hazard ratio 1.23. So it means the question for you is, those patients with favorable risk are really benefiting from immunotherapy at any time? Or we can, well, keep the immunotherapy with us and use the immunotherapy almost 2 years after, when the patient is progressing to the single agent tyrosine kinase inhibitor, and we can offer in a subsequent line of treatment. I am not saying that we should not offer for immunotherapy to our patients with metastatic renal cell carcinoma. I am just simply saying that probably there are some patients in which immunotherapy could be reserved for subsequent lines of treatment in our patients, particularly those patients with favorable risk. How do I see these tumors? How do I make my personal approach when I'm facing a patient with renal cell carcinoma, with metastatic renal cell carcinoma? Well, for me, this is very easy. We have in one hand those patients with favorable risk, and in the other hand, those patients with poor risk, and in the middle, all the subgroup of patients that you want to. For me, there is a clinical translation in between this data and the molecular biology data, particularly angiogenesis enriched microenvironment versus immune infiltrated enriched microenvironment. Those patients with favorable risk or favorable features, they have more angiogenesis, more blood vessels on its tumor. Those patients with more aggressive features, well, unfortunately, they have more inflamed, more fibrosis on their tumor microenvironment. This is translated into the clinic. And those patients with favorable risk, well, they have 0 or 1 adverse prognostic factors. Very good outcome is expected here. Unfortunately, well, these patients are less likely to respond to immunotherapy. The other thing is happening with those patients with more aggressive tumors. Those patients with more aggressive disease, normally they have more symptoms, a higher tumor bulk. And unfortunately, the response to TKI, because of the lack of blood vessels, is less. But the response to immunotherapy, because of these higher tumor cells, immune tumor cells infiltration, is higher. The key thing here, and the question here is, okay, we have these tumors that are benefiting more from receiving TKI, and maybe TKI can be the single agent to offer to our patients with metastatic renal cell carcinoma. However, what is the threshold? Unfortunately, we don't have a good biomarker to predict which will be these patients who will be longer benefiting to receiving a single agent TKI in the first line. Okay, we offer to these patients, this lady with 57 years old, treatment with sunitinib, and she was on treatment for 16 months. Unfortunately, after 16 months, or almost 1 year and a half, the tumor progressed. And now we need to decide of what to do with this patient. And we have two options in the clinic. We have, well, to go for another subsequent tyrosine kinase inhibitor or to go for an mTOR inhibitor. These were the two options that we used to have before the immunotherapy. Now, well, nobody has this doubt in the clinic. Now, data, not only coming from the clinical trials, but coming from the real world setting, are clearly showing that tyrosine kinase inhibitors are better, at least in terms of overall survival and progression-free survival, comparing to mTOR inhibitors. So, okay, we have two, well, most used tyrosine kinase inhibitor in the second line setting. We have axitinib and we have cabozantinib in this field. And I think today nobody doubts that they both are better than everolimus. Okay, so let's focus on the use of tyrosine kinase inhibitor as a subsequent line of treatment after failure to another TKI. Well, these are the main outcome, the primary endpoint of the AXIS trial, the phase 3 trial, the pivotal trial that compared axitinib versus sorafenib in patients with metastatic renal cell carcinoma. Once again, I want to use the common sense. When I am using one or another alternative, when I am using axitinib or nivolumab or cabozantinib in my patients in daily practice. Well, I think for me, this is, again, very easy. This is depending on the common sense again, depending on how rapid, how aggressive my patients are progressing to the first tyrosine kinase inhibitor I'm giving. If I have these kind of patients, primary refractory, those patients that are in which the tumor is growing very fast, very aggressively, well, definitely the tyrosine kinase inhibitor is not really working. I need to attack the tumor the stronger as I can. Well, probably the strongest way to attack this tumor is both the combination of lenvatinib plus everolimus, probably the most active thing I can offer to my patients in the second line setting, but the most toxic. And we have also the opportunity to offer for cabozantinib, a very aggressive tyrosine kinase inhibitor, very potent as well. When I say potent, when I say aggressive, means activity, which is great. But at the same time, it means probably, or it is linked to toxicity. So we need to balance these two things, activity in one hand and toxicity. For those very rapidly and very aggressive tumors, well, probably we need to attack with the highest and more potent things that we have, maybe leaving aside all the adverse events that we may have. Otherwise, we will lose these kind of patients. Intermediate progressors, and when I say intermediate progressors, means those patients that are progressing in between 6 and, let's say, 16 months of treatment, which are the majority of the patients, well, probably immuno-oncology drugs like nivolumab as a single agent or axitinib can give good drugs for them. And for those patients, particularly with very slow-growing tumors, those patients in which the TKI is working, but it is controlling the tumor growth, but unfortunately the growth of the tumor is still there, well, probably a single agent like axitinib can still control the disease. And what to do for those patients with long-term benefit to the first tyrosine kinase inhibitor we are doing? Well, it will depend on how rapid the tumor is growing. But probably insisting on tyrosine kinase inhibitor pathway can be a good choice for the treatment. So these are the options that we have. Which one is better? Choose yourself. Use whatever of this drug you wanted, but use it well. try to balance this activity with the side effects profiling and try to offer immunotherapy if your patients have not received it before. What is the percentage of patients with this kind of behavior, with this kind of a tumor growth rate? Well, probably we have like 20% of patients that are primary progressive. Most of the patients, as I mentioned before, will be intermediate progressors. And long-term clinical benefit with the first tyrosine kinase inhibitor are up to 10 to 20% of our patients. There are many other factors that can influence in our decision making. For instance, if you have a patient with bone metastases, well, probably cabozantinib, because one of the off-target of the drug is hitting the MET, and we know that MET is overexpressed in bone metastases. Well, probably cabozantinib can be the preferred choice of treatment for patients with predominant bone metastasis disease. What about for patients with very bulky tumors, as I mentioned before? Well, the highest response rate is coming from the combination of lenvatinib and everolimus. Why not to try to offer for this combination to these kind of patients? Patients with favorable risk, patients with very slow growing tumors when progressing to the first tyrosine kinase inhibitor, axitinib, a potent and very selective anti-angiogenic agent can be your choice of treatment. And what about those patients who are experiencing for toxicity when using the first tyrosine kinase inhibitor? Well, let's switch the mechanism of action. I mentioned before that everolimus is not one of the key drivers here. Let's go for immunotherapy, nivolumab as a single agent. Because nivolumab can work both, not only in the second line, but also in the third line setting. Don't be afraid to delay the use of nivolumab in your treatment, particularly with favorable risk. The clinical benefit of nivolumab in the second line setting was based in a phase 3 trial, the Checkmate 025 trial, in which it showed the superiority for overall survival of nivolumab versus everolimus. Take a look at the magnitude of the difference of the activity of nivolumab in second and third line setting, and in the patients with favorable, intermediate, and poor risk. Nivolumab is focused, the benefit of nivolumab, and I would say the benefit of immune-oncology drugs in general in the field of renal cell carcinoma is mostly focused to those patients with at least 2 or 3 adverse prognostic factors or Hens criteria. Once again, and same that happened in the first line setting, immunotherapy is working better for those patients with more aggressive tumors. So let's focus on that to offer for immunotherapy. These are my conclusions, my last slide. And I think we are all happy that we all that are related to the treatment of patients with renal cell carcinoma are happy, because now we have a broad range of different options to offer to our patients. But despite of the use of the penetration of immune-oncology drugs, tyrosine kinase inhibitors, anti-angiogenic inhibitors are still the backbone treatment for our patients in the clinic. Axitinib is one of the most potent and selective tyrosine kinase inhibitors that we can have in this field, no matter if we are using in combination in first line with pembrolizumab or with avelumab, or as a single agent after failure to any other first line treatment that we have. This is one of the key things that we can offer to our patients. Of course, the use of combination based on immunotherapy in the first line setting are conditioning what can we use in the second line setting. Thank you so much to all of you for your attention, and I will be happy to address all the questions that you may have if I know. Thank you.
Thank you very much, Professor Grandi, for this outstanding and comprehensive talk. We have time for a few questions. Maybe I start with the first question. You illustrated nicely in first line setting, patient with favorable risk stratification. Maybe you don't need combination chemotherapy. This stratification, as you mentioned, it's based on the IMDC consortium risk stratification. Do you take in consideration when you make your decision the histology of the renal cell carcinoma and genetic profiling upfront before you select between these many options we have nowadays?
Absolutely. Thank you so much, Dr. Fauci, for this question. In my first slide, I showed that renal cell carcinoma is not a single entity at all. If you are facing a patient with papillary tumor, or at least with papillary component, you need to think that probably c-MET alterations, mutations, amplifications will be there. And cabozantinib probably will be the driver when dealing with these kind of patients. But if you are facing a patient with sarcomatoid histologies, well, probably the angiogenesis component is very low. So probably you need to think before about immunotherapy when dealing with these kind of patients. Same thing happens when you are facing a patient with collecting ducts, a carcinoma, or patients with translocation on the chromosome X. Well, probably you need to treat these patients with immune-based combination or immune-based approaches. So definitely we need to work together, pathologists, molecular biologists, and oncologists in the future to try to tailor the treatment.
Any other question? Maybe.
Yeah.
Yeah.
About I will ask about patients with stage 4 RCC. Did that's for think adjuvant treatment or palliative.
الدكتور بس غلبك تعلي صوتك لأنه كثير واطي غلبك كمان مرة. دكتور كمان مرة تعيد السؤال. بس صوتك شوي كان واطي بس تغلبك تعليه. علي غلبك شكرا.
يعني in case of metastatic RCC and in case of we did a metastectomy for a patient, do you think we need further treatment in such cases?
I'm really sorry. Can you please repeat the question? I think I don't get it.
Maybe I summarize the question. If the patient has oligometastasis and you did resection for this metastasis, you consider systemic therapy after surgery?
That's a lovely question. Thank you so much for it. Well, we have two phase 2 trials with tyrosine kinase inhibitors. We have one with sorafenib and another one with pazopanib in comparison with placebo, that in the adjuvant setting, after fully removal or radiotherapy, SBRT of these oligometastases, tyrosine kinase inhibitors are not working to delay the time to tumor growth. Now, with the recent phase 3 trial, the Keynote 574 trial with Pembrolizumab, there is a subgroup of patients which are metastatic with this oligometastasis, fully resected, in which Pembrolizumab, it is impacting in the delay of the tumor growth. So maybe Pembrolizumab can be considered a good option for these kind of patients. But definitely, if you can pursue, if you can remove all the metastases, no matter if we are talking about surgery or SBRT, radiotherapy, let's go for it, because this is clearly impacting in the overall survival of these patients. Thank you for your question.
Okay, maybe I ask another question about the use of combination treatment in the second line setting. As you mentioned, most of the trial about the combination, they are in the first line setting, but if you see some of the guidelines like the NCCN guidelines, based extrapolation on the data from the first line, they consider using combination even in the second line. What's your approach on that?
But you mean for the second line setting after failure to combos?
If the patient failed the first line and he wasn't suited, now he progressed, would you consider just single agent or combination?
Well, if I forget about the access, I'm happy with offering Nivo-IP. But if the indication is just for Nivo single agent. Or you mean the other way around? When you are treating your patients in the first line setting with a combo base, immune combo base, what is the role of shooting after?
Any other question?
Mm-hmm.
Okay, there is no more question. I would like to thank Professor Grandi for this excellent talk and hope to see you in Jordan in the near future. Thank you very much.
Thank you so much. Thank you all. Bye.
Thank you all for attending the lectures. We have break for 10 minutes till the second lecture.
Hello? Here's Martin Drake.
Hello. How are you, Dr.
Hello.
Rek?
Hello. Hi.
Hello. How are you doing?
I'm okay, thank you.
You're welcome. So this is your virtual visit to Jordan. Hopefully,
Yes, yes, yes. Unfortunately, only
you will come in
the-
person soon. We were just talking how much it's comfortable, you know, to have virtual conferences from the comfort of your home. You can reach anywhere in the world.
Yeah, that's true.
But I can't trade it with the in-person meeting. Hopefully, we will be back to the in-person meeting. We miss the networking.
Yeah, yeah. We will start with the European Lung Cancer Conference, and hopefully we will have a chance at ASCO. So
I think ASCO is happening. You know, it's in person and hybrid. I think it's happening.
it's
I'm
a
going there.
hybrid meeting. Yes, you are completely right. Yes.
Unless the war extends, huh?
Yeah, yeah. This is a very, very unfortunate situation. But hopefully there will be some clearance in the next days.
So we need a couple of minutes before you start, like 4 minutes.
No problem. I'm okay. I just Can you see my slides now?
What's that?
Can you see my presentation?
He's asked about his presentation. This is his presentation. Okay. Can I give him any control or?
No,
He has the
I'm
he has the control.
presenting. Yeah. Do you see my slides?
Yes, we can see your slides.
Okay. So,
Okay.
perfect.
So let's start. So with all pleasure, me and Dr. Arafat, we are happy to introduce with great pleasure Professor Martin Rick, who's a very well-known figure in Europe and the world in the management and treatment of advanced stage non-small cell lung cancer and mesothelioma. He is the principal investigator and the co-PI in various clinical trials, focusing mainly on immunotherapy since 1993. His main interest is in targeted therapies in non-small cell lung cancer, new approaches in small cell lung cancer, and modern therapy in malignant pleural mesothelioma. Dr. Rick is the head of the Department of Thoracic Oncology, as well as the head of the clinical trial department in the Department of Thoracic Oncology in the Lung Clinic and Gross-Handorf Clinic. Furthermore, he is PI in the German Center of Lung Research, DZL, in the area of lung cancer. Professor Rick is a member of the German Working Group for Lung Cancer. Without further delay, we invite Dr. Martin Rick for his presentation.
Yes, dear colleagues, thank you for the great invitation. It's a pleasure to be with you. Unfortunately, I only can see you on the computer, on the virtual screen. It would be much better to have you face to face in Jordan. Hopefully, in the next time, we will have some opportunity to meet in person. However, I think it's a good time to talk about new approaches, new achievements that we have seen in patients with non-small cell lung cancer. And it's a pleasure to talk to you about the latest developments in the field of non-oncogenic driven non-small cell lung cancer, what is new, and what might we expect from the future. So these are my conflicts of interest, and this is a disclaimer. So this is a scientific meeting, and I'm very, very happy to discuss very early and hypothesis generating information. And of course, some of these information are not related to approved therapies. Well, when we look on the development of therapeutic opportunities for patients with non-oncogenic driven non-small cell lung cancer, I think the most relevant change has been with the implementation of checkpoint inhibitors, with the implementation of immunotherapies into the treatment of patients with advanced non-small cell lung cancer. So we started with the use of checkpoint inhibitors in pre-treated patients. We have 4 randomized trials comparing a monotherapy with a checkpoint inhibitor to a standard chemotherapy, which was docetaxel. And in each of these trials, we have seen a significant prolongation of survival and a persistent prolongation of overall survival compared to chemotherapy. And following these results, we changed the place of immunotherapy to be now the standard of care in first-line treatment of patients with advanced non-small cell lung cancer. And on the right side, you can see that we have a variety of positive trials also in the first-line setting of patients with advanced non-small cell lung cancer. And something which has been quite unexpected but very, very pleasant has been the impact on long-term survival. So for the first time, in particular when we look on patients with non-oncogenic driven non-small cell lung cancer, we have got something that we would call a taste of a chronic disease. So on the top line, you can see the long-term follow-up for the phase 1 trials for Pembrolizumab, the Keynote 001 on the left side, or for Nivolumab, the Checkmate 003 on the right side. And for the first time, we were able to report 5-year overall survival data. We really did see a lifting of the tail of the overall survival curves. And when you look on the curves below, these are the long-term follow-up data for the randomized second-line trials, the Keynote 10 for Pembrolizumab on the left side, and a pooled analysis of the Checkmate 17 and 57 on the right side. You also do see that there is a persistent benefit of the immunotherapy in the randomized trials compared to chemotherapy. So this really has been a major step in our therapeutic opportunities. And now we really have a huge range of opportunities which we can offer our patients in the first-line setting. So we have the monotherapies with Pembrolizumab, Atezolizumab, or Gemiplimab in the group of patients with high PD-L1 expression on the tumor cells or high PD-L1 expression on immune cells for Atezolizumab. There we may use this checkpoint inhibitors as a very efficacious and well-tolerable treatment as a monotherapy, but we also do have the opportunity to combine checkpoint inhibitors either with chemotherapy, and this is now the standard of care, which we would offer our patients, or we also can offer patients a double immunotherapy with a short chemotherapy. This is a novel opportunity which we have generated last year, and this is something which is an opportunity for patients independent from the PD-L1 expression status. So this is something where we also have seen a superior efficacy in patients with intermediate PD-L1 expression or even PD-L1 negative tumors. Well, the question is, how are we going to move forward? Also, when we think about the term of cure, and there we have two very important areas where immunotherapy also has shown a significant efficacy. And the number one is the stage of locally advanced stage 3 non-small cell lung cancer. And this is a setting where we do see a non-surgical treatable disease, but we also do have the evidence that there are no distant metastases. And from the mode of mechanism, it makes sense to move into earlier stages of disease where we do not have that dominant tumor, because the chance of the immune system to overcome the tumor is greater when we have a less dominant tumor burden. And then we really have the chance that the immune system, that the immune activation might either control the tumor or may even eliminate the tumor. And the landmark trial in this setting has been the Pacific trial, where patients with a locally advanced non-small cell lung cancer after chemoradiotherapy were randomized to a consolidation treatment with the anti-PD-L1 antibody Durvalumab or placebo. And the co-primary endpoints were progression-free survival and overall survival. While looking on the trial results available for stage 3 non-small cell lung cancer, this has been the first positive trial for a consolidation treatment approach. So we have seen a significant improvement in progression-free survival and overall survival, favoring the consolidation treatment with Durvalumab. And again, we have seen a consistent benefit in both endpoints. Last year, we presented the 5-year efficacy data. We have seen a 5-year progression-free survival rate of 33% compared to 90% with a hazard ratio of 0.55. And we also have seen a 5-year overall survival rate of 43% compared to 33%. And I think this is a remarkable improvement in efficacy. And this is also something which has something to do with cure of the patient. So this is now standard of care, the consolidation treatment with Durvalumab after chemoradiotherapy in patients with stage 3 non-small cell lung cancer. In Europe, we have the approval for the PD-L1 positive patients. We also have seen in the Pacific trial that there is a correlation between the treatment interval after stop of radiotherapy and implementation of the consolidation treatment. The shorter the interval between the stop of radiotherapy and the start of the consolidation treatment, the better the efficacy. And this has led to the next generation of trials in stage 3 non-small cell lung cancer. And this is one example. This is Keynote 799, looking on a combined chemo-immunoradiotherapy in stage 3 non-small cell lung cancer. This is not a randomized trial. This is a trial in 2 different chemotherapy cohorts investigating this novel approach of putting the immunotherapy into the multimodal treatment approach of chemoradiotherapy. And the two primary endpoints that we developed for this trial were, on the one hand, the efficacy. This was respected by the response rate. And on the other hand, the tolerability. It is clear that there were some concerns of potential immune therapy-induced lung toxicity. So this was the key toxicity which we assessed as the second co-primary endpoint, the rate of grade 3 and 4 treatment-related lung toxicities. Well, when we look on the efficacy data, the response rate was quite impressive, with a response rate around 70.5, 70.6%. Currently, we do not really have the median progression-free survival or median overall survival, but we do see a 1-year progression-free survival rate between 67 and 71%, and a 1-year overall survival rate between 81 and 87%. The efficacy was independent from histology, and it also was more or less independent from the PD-L1 expression status. Looking on the tolerability, as mentioned before, the key adverse event was the grade 3 and 4 rate of treatment-related pulmonary toxicities, and we had defined a cutoff of 10%, where we said, well, if we do see a pneumonitis rate higher than 10%, I think we have to stop this regimen, but the rate was between 7 and 8%, clearly below this threshold. So overall, this is a feasible and very effective regimen, which is currently investigated in prospective randomized trials. This is one example, the KEYLINK 12 trial, comparing this intensive chemoimmunoradiotherapy followed by maintenance with immunotherapy to the standard PACIFIC schedule. And there's also another part in the maintenance investigating the combination with a PARP inhibitor in the consolidation period. Well, the other way to improve the outcomes of the consolidation treatment are novel immunotherapy combinations. And we do have two very interesting checkpoint inhibitors available. One of them is the Oleclumab, which is a CD73 antibody, and the Monalizumab, an NKG2A antibody. And last year at the ESMO meeting, we have seen some quite interesting results coming out from the COAST trial. This was a randomized phase 2 trial investigating novel immunotherapy combinations against the standard of durvalumab consolidation with the primary endpoint of response. And we have seen an improvement of the response rate and of the progression-free survival in favor of this novel immunotherapy combinations, in favor of the combinations with the new checkpoint inhibitors. And this is also something which goes now to phase 3 concepts. We have the PACIFIC 8 and 9 trials exploring these novel immunotherapy combinations as potential treatment opportunities for consolidation treatment. Another pathway, which is also in the center of interest now for new immunotherapies, is the PVR-TIGIT axis. And we do have the tiragolumab as an anti-TIGIT antibody, which has shown a tremendous efficacy in the CITYSCAPE trial. And we know that the PVR-TIGIT axis is a novel opportunity also to reactivate the microenvironment in the immunosusceptibility of the tumor. And we also have a tiragolumab trial available in stage 3, exploring the combination of tiragolumab and atezolizumab compared to durvalumab as a new consolidation strategy in stage 3 non-small cell lung cancer. Well, moving now from stage 3 to the resectable non-small cell lung cancer. And there we also do have two very interesting areas. Number one is the adjuvant therapy, and number two is the neoadjuvant, the pre-operative treatment. Well, we know that we have to do something in addition to surgery, even in patients with early stage non-small cell lung cancer. The survival curves are not as good as we would expect from a tumor that we can treat radically by surgery. We do see relapse rates in 30 to 55% of our patients with early stage non-small cell lung cancer despite surgery. And when we look on the picture of the relapse patterns, there's a huge number of patients who do suffer from a distant relapse, who do suffer from the new appearance of distant metastasis, which means we really have to do something in the systemic control of our patients following surgery of early stage non-small cell lung cancer. Well, the first approach has been to look for the efficacy of perioperative chemotherapies. So we have done various studies exploring adjuvant chemotherapy and neoadjuvant chemotherapy. Overall, the efficacy seems to be comparable, regardless whether we are offering the patient an adjuvant or a neoadjuvant schedule. The improvement in the overall survival was modest, with an improvement of the 5-year overall survival rate of 5%. So there is clearly enough room, enough space to improve the efficacy of systemic perioperative therapy. We have one example how we can move forward, and this example is coming from the group of patients with oncogenic alterations. So we have seen the outcomes of the AD-AURA trial investigating the efficacy of an adjuvant EGF receptor TKA in patients with resected EGF receptor mutated non-small cell lung cancer. And we have seen a clear signal in the improvement of disease-free survival and also in the improvement of metastasis control in favor of this adjuvant targeted therapies. Well, the other way is to look on those patients without oncogenic alterations. And the question is whether we do have a good rationale to use checkpoint inhibitors in this setting. And the first question was, what do we really know about the microenvironment of early stage non-small cell lung cancer? And we do have the outcomes from this very elegant trial investigating the microenvironment composition in patients who have been resected for an early stage adenocarcinoma. And when we look on the composition of the microenvironment of this early stage adenocarcinoma in comparison to the microenvironment of normal lung tissue, we really have seen that there are a lot of tumor immunosuppressive cells present in the microenvironment of this early stage adenocarcinoma. So we do really have a good rationale also to explore checkpoint inhibitors as an opportunity for perioperative treatment. Well, there are a couple of challenges when we look on perioperative immunotherapies. And the first one is the question, how shall we move forward? Shall we go for neoadjuvant or adjuvant immunotherapy? And when we are conducting our clinical trials, we also have to look on the clinical reality. What is happening in our cancer centers? How are patients with lung cancer treated in reality? And what would be the paradigm change that we would implement with a novel treatment? So starting with the first point, neoadjuvant versus adjuvant immunotherapy, we have two principles. So in the adjuvant immunotherapy, we are dealing with a resected tumor. So the goal of the adjuvant checkpoint inhibitors is to work on the remaining tumor cells to foster a long-lasting control over these remaining tumor cells and to prevent the relapse of the disease. The situation is a bit different when we talk about the neoadjuvant immunotherapy, because there we do have the tumor present, we do have the antigen presentation in the tumor, and we might expect a somewhat more heavier immune reaction when we expose the patient to a neoadjuvant immunotherapy, either alone or in combination. On the other hand, there might be the chance that also the efficacy might be a bit more impressive by a neoadjuvant immunotherapy. While The truth is we do not know what is the better approach. So far, the only potential benefit for a neoadjuvant immunotherapy compared to an adjuvant immunotherapy has been shown in tumor models. So we have some data for a breast model here on the left side showing a better tumor control for the animals who have been treated with a neoadjuvant immunotherapy. And very recently, we also have seen some similar data coming out for a non-small cell lung cancer model. But the question is this really enough to convince us in clinical practice? I think we really need clinical data. We need clinical trials to compare the neoadjuvant to the adjuvant approach of immunotherapies. The other point is the clinical reality. And I had a look on the registry of my cancer hospital. So I looked on all the patients who received a resection in the recent 8 years at my institution. And I have to say that 14% of them received a neoadjuvant therapy. The majority of these patients were patients with locally advanced tumors, nodal positive tumors. And when I look on the patients with real early stage non-small cell lung cancer, the N0 or the N1 disease, less than 3% of these patients received a neoadjuvant chemotherapy. So a change to a neoadjuvant immunotherapy really would mean that we would have to change our complete therapeutic algorithm for our patients with early stage non-small cell lung cancer. Well, these are the data from my institution, our lung cancer hospital, but I found very similar data also in the literature. So these are data from a National Cancer Database on more than 35,000 patients who had been operated for an early stage non-small cell lung cancer. And again, the frequency of neoadjuvant therapy was in the range of 3%. And when we look on the frequency of neoadjuvant chemotherapies in stage 2 non-small cell lung cancer, this was even less with 2.4%. So again, the implementation of a neoadjuvant systemic treatment really would mean that we would need to change our therapeutic algorithm completely. Well, coming back to the questions and the challenges, the next important question is, when might we expect results? And this has something to do with the endpoints that we are designing for our trials for perioperative therapies. And as mentioned before, we are coming from adjuvant, we are coming from neoadjuvant chemotherapy. And when we look on these old data, the time between the recruitment of the first patient and the publication of the final trial results was in a range between 10 to 12 years. This is a time frame which is clearly not acceptable nowadays. We really need our results of the trials much faster. So we have to look for alternative endpoints for our trials for perioperative treatments. And there we have found two very interesting categories of potential efficacy endpoints. One of them is the event-related endpoint, disease-free survival or event-free survival, which now is an, for example, accepted endpoint for perioperative trials in breast cancer. Or we can look on endpoints focusing on the tumor response, in particular focusing on the pathological tumor response. So we can look on the pathological tumor remission associated with the perioperative therapy. And there we have designed two terms. Number one is something that we call a major pathological response, which means that we have less than 10% of residual tumor tissue evident. And the other one is the complete necrosis, the pathological complete response, which also has an association with the therapeutic benefit. So we do have correlational trials looking at the correlation between disease-free survival and overall survival, And on the left side, this is an example of a meta-analysis showing a very close interaction between the prolongation of the disease-free survival and the improvement in overall survival. And we also have very similar data showing a correlation between the pathological complete response and the impact on overall survival. We have to be a bit careful because all of these correlations have been generated for neoadjuvant or adjuvant chemotherapy. So far, we do not have these correlations available for perioperative targeted therapies, and we also do not have these correlations available for perioperative immunotherapies. However, we do have these correlations as a potential first step to build on the designation of endpoints for our perioperative trials. So let's have a look on the data. And I would like to start with the neoadjuvant immunotherapy. And in principle, we had two avenues that we explored for neoadjuvant immunotherapy. The first step was to look for the neoadjuvant immunotherapy with a monotherapy with a checkpoint inhibitor. So we have a number of non-randomized phase 2 trials looking on the efficacy of neoadjuvant nivolumab, atezolizumab, or pembrolizumab, and we have seen major pathological rates in a range between 14 to 45%. And when we look on the rate of pathological complete responses, and I think these are the more important outcomes, we do see a frequency between 0 and 15%. Of note, we never saw meaningful radiological responses by neoadjuvant immunotherapies. We also have seen that there is an opportunity to increase the pathological efficacy by adding chemotherapy to the checkpoint inhibitors. So when we look on the outcomes related to the combination of a checkpoint inhibitor and chemotherapy, we do see an increase in the major pathological rate from 60 to 85%. And we also have seen an improvement and an increase in the rates of pathological complete response with PCR rates between 18 and 59%. So when you look on the randomized trials, the majority of these trials really investigates the combination of a neoadjuvant chemotherapy and a checkpoint inhibitor. And the first trial which was presented is the Checkmate 816, exploring a neoadjuvant chemoimmunotherapy with nivolumab and the platinum-based chemotherapy compared to platinum-based neoadjuvant chemotherapy in patients with resectable stage 1B to 3A non-small cell lung cancer without oncogenic alterations. So the patients received 3 cycles of chemo or chemoimmunotherapy, and then a resection was scheduled within a time frame of 6 weeks. And afterwards, an optional adjuvant therapy plus or minus radiotherapy was offered to the patient. The two co-primary endpoints were, on the one hand, the pathological complete response rate by an independent review of pathologists or the event-free survival. Well, so far we have seen the results for the first co-primary endpoint, the PCR rate, and there was a clear improvement in favor of the patients who received the neoadjuvant chemoimmunotherapy with a PCR rate of 24% compared to 2.2% in the neoadjuvant chemotherapy, corresponding to a p-value of less than 0.0001. And also the depth of the remission was impressively increased in the group of patients who received the chemoimmunotherapy as a neoadjuvant therapy. We also have seen a press release on the second co-primary endpoint, which has been the event-free survival, that this also was significantly improved in favor of the neoadjuvant chemoimmunotherapy, but so far we haven't seen the full data. This is something that we are going to expect. This is something which we are expecting to see very, very soon. Well, the question is, what about the tolerability and the feasibility of surgery after neoadjuvant chemoimmunotherapy? As mentioned before, we may expect a somewhat more heavy immune reaction in the patients who are receiving a neoadjuvant immunotherapy. So far, we have these complication data available. There was no difference between the two arms in the Checkmate 816. And also, when we look on the resection rates, these were completely comparable between both of the rates. So we have a good story. On the one hand, when we look on the pneumonectomy rates, they were completely comparable between both of the arms. And also when we look on the RM0 resection rates, they were completely comparable between both of the arms. The question is whether this is really sufficient for good surgical quality. And at least in Germany, I have to say that an R0 rate between 78 and 83% is not sufficient for good surgical quality. And the same is true with the rate of pneumonectomies between 17 and 25%. So this is something where we clearly need more information about the surgical quality within the Checkmate 816 trial. While this has been the first trial which has been presented, there are a lot of new trials also to be presented in the next 2 years. We have the IMpower 030 exploring a neoadjuvant atezolizumab combination. We have other nivolumab trials, but we also have trials investigating pembrolizumab or durvalumab as a neoadjuvant immunotherapy in combination with the chemotherapy. Well, what about the adjuvant immunotherapy? And there we have another trial which was presented recently, and this is the IMpower 010 trial. So in the IMpower 010 trial, patients with a resected non-small cell lung cancer stage 1B to 3A and who had received 1 to 4 cycles of adjuvant cisplatinum-based chemotherapy were randomized to atezolizumab as an adjuvant immunotherapy compared to best supportive care. And the primary endpoint here was disease-free survival in PD-L1 expressing tumors. Well, when we look on the outcomes, there was a significant improvement in disease-free survival favoring the adjuvant immunotherapy with atezolizumab compared to best supportive care. We have seen a 2-year disease-free survival rate of 75% compared to 61% in the control arm. And this was corresponding to a hazard ratio of 0.66. Overall, we did observe consistent benefit of the adjuvant atezolizumab across all investigated subgroups. There were two very important messages coming out of this subgroup analysis. Number one, there was a correlation between the PD-L1 expression on the tumor cells and the efficacy of the atezolizumab, favoring those patients with a high PD-L1 expression on the tumor cells. And number two, there was also a difference in efficacy related to the mutational status. So there was no benefit in disease-free survival in those patients presenting with an activating EGF receptor mutation or an ALK translocation. So far, we do not really have good data for overall survival. The data are still immature. We do see a trend, but we clearly will need further follow-up to explore the full effect on overall survival by the adjuvant immunotherapy with atezolizumab. Looking on tolerability, well, we didn't see any new signals on safety with the adjuvant atezolizumab. There were some patients with treatment-related adverse events. The majority of these treatment-related immune adverse events were mild to moderate, and the frequency of grade 3 to 4 treatment-related adverse events was very low, and the majority of these immune-related adverse events could be managed by steroid implementation or other modifications of the treatment. So following these results, the FDA has approved atezolizumab as an adjuvant treatment for non-small cell lung cancer in patients with PD-L1 expressing non-small cell lung cancer. And we are also expecting to get some signals from the EMEA hopefully this year regarding a potential approval of atezolizumab as an adjuvant therapy. Well, the IMpower010 has been the first trial, but similar to the neoadjuvant field, we may expect more data to come out. We have heard in the press release that the PEARLS trial investigating adjuvant Pembrolizumab also has been positive in terms of improving disease-free survival, but there are a couple of more trials coming up in the next months and years. Well, another question is the question of treatment selection. And of course, we would like to know, are we able to identify those patients with the highest risk for relapse who are definitely in need of an effective adjuvant therapy? And we have got a very interesting analysis which has been presented last year at the ESMO IO, looking on the role of ctDNA in patients with resected non-small cell lung cancer. So in the IMpower010 trial, there was an exploratory analysis looking on the correlation between the ctDNA and the prognosis of the patients. So the patients received a ctDNA sample, which was retrospectively tested using the Natera Signatera assay. And the first important signal was that indeed there was a correlation between the ctDNA presence and the disease status. There was a higher frequency of ctDNA positive tumor patients in patients with locally advanced stage 3A non-small cell lung cancer and in patients with nodal positive tumors and 2 tumors. And interestingly, there was also a higher presence of ctDNA positive signals in the group of patients with known EGF receptor mutation. Similar to other findings, the ctDNA status represented a clear prognostic factor. Patients with ctDNA positive tumors or ctDNA positive diseases had the inferior prognosis compared to those patients with ctDNA negative diseases. Independent from the ctDNA status, there was a clear improvement of the prognosis of the disease-free survival in those patients who had received the adjuvant treatment with atezolizumab. Looking on the effect of the atezolizumab in the group of patients with ctDNA positive diseases or tumors, the major effect was seen very similar to the ITT in those group of patients with PD-L1 expressing tumors. So this could be an additional factor which might be of importance for the future to identify those patients who are definitely in need of an adjuvant therapy. Having said this, when we talk about immunotherapy in early stage non-small cell lung cancer, when we talk about the next steps of immunotherapy, we have seen a clear signal of efficacy for immunotherapies in neoadjuvant and in adjuvant immunotherapy. And we also have seen this in consolidation treatment of locally advanced non-small cell lung cancer. The role of disease-free survival and pathological complete response as a surrogate marker needs to be defined. We only do have the correlations for chemotherapy, but for one time, we need to confirm this also for immunotherapies. I think the battle for the pool position has started. The target group needs to be determined. We have to talk about the duration and the dosage of the immunotherapy and the chemotherapy. This is still completely unclear. How long really shall we treat a patient with an adjuvant immunotherapy? The surgical quality and the safety needs to be defined. However, I think we are really living in exciting times. We have the chance to improve the cure of our patients with non-metastatic non-small cell lung cancer by the use of immunotherapy. We have the first exciting outcomes coming out from randomized phase 3 trials. And I think this is another significant step in the implementation of immunotherapy in management of patients with non-small cell lung cancer. Having said this, I would like to thank you for your kind attention and I'm open for your questions.
Professor Rick, thank you for presentation. We have time for many questions. Floor is open for questions, please. Any question?
Yeah, can I start with the first question? I'm not sure if my voice is clear or no.
That's very
I
clear.
Yeah, I guess I have the mic now. It's very interesting, you know, the progress that's happening with the immunotherapy. It is a pillar now in lung cancer and many other cancers. But the progress from stage 4, from second line stage 4 to, you know, to the approval, recent approval in adjuvant, and probably to the neoadjuvant. It's really exciting times, as you mentioned. I'm more excited about the neoadjuvant idea in lung cancer, you know, before surgery, giving that you're going to give like limited number of doses. Like look at the all neoadjuvant trials, they are giving even with or without chemotherapy. There are a couple of doses, 3 to 4 doses of immunotherapy, you know, and then the patient will go with the practice. And you will have more, you know, more tumor burden. So you expect theoretically to have more action from the immunotherapy, you know, in comparison to the adjuvant trial. Do you expect soon that we will get new adjuvant approval also in lung cancer? And when this happens, where do you think the standard of care will move to?
This is a good question. So I think when we are going to see a positive second co-primary endpoint for the CheckMate 816, we have the first randomized phase 3 trial meeting the 2 co-primary endpoints. And I think this will definitely lead to some approval. And I think the question then will be positioning of the neoadjuvant therapy. And I think this is something where we need the multidisciplinary discussion, because there's something which has to be clarified with the surgeons as well. And I can tell you, at least from Germany, not every surgeon is very excited about this neoadjuvant therapy, because it's still a delay of the resection. There is still a risk of some complications. There is the risk of some adverse events which may limit the resectability of the tumor. And I think we really will need to look on the different subgroups of the patients who have been included in the trial to define those patients who really benefit best from this neoadjuvant approach. I completely agree that the concept is intriguing. I definitely do believe if this is going to work also in lung cancer, this will be a new opportunity. The problem is the CheckMate 816 is the only trial which investigated a pure neoadjuvant therapy. So when you look on the design on all the other trials which are exploring the neoadjuvant chemoimmunotherapy, nearly all of them do not only investigate the neoadjuvant chemoimmunotherapy, they also have a second part, which is an adjuvant immunotherapy compared to best supportive care or placebo. So the question is, when these trials are going to be positive, is this really related to the neoadjuvant part of the therapy, or is this also related to the adjuvant part of the therapy? And this is going to cause us a lot of headache in the near future when we are going to define the optimal perioperative therapies for our patients.
Any questions?
Any questions?
Do you have any question in the platform? Okay. So do you expect that, you know, the data about CT circulating DNA, tumor DNA, is really another interesting thing. It really could classify the patient and decide who are the patients that they're gonna receive adjuvant or will not receive adjuvant, and for how long? How do you see these data coming out?
So I think this is really one of the interesting new marker. And I think there are two ways how to use the ctDNA. So in metastatic stage of disease, we are now starting to use this as a potential dynamic marker of efficacy. So we are looking on the ctDNA clearance, which can tell us something about the efficacy of the therapy. But we also may use this as a potential selection instrument for using perioperative therapy. So as you know, when we started with the adjuvant chemotherapies in non-small cell lung cancer, we did have the problem that we had a lot of overtreatment for a couple of patients who were not really in need of an adjuvant chemotherapy. So this might be the first chance to identify the first patient, to identify those patients who are definitely in need of an adjuvant therapy. This is clearly something which needs to be confirmed in prospective assessments. And I know that this ctDNA now is incorporated as a translational marker, as an exploratory marker in the majority of trials investigating new approaches of perioperative therapy. So I expect a lot of new information coming up in the next years. So far, we can say it's a clear prognostic marker. It's not so clear whether it serves as a predictive marker for treatment, so the test of interaction was not significant, but it does have an importance of selecting our patients, which needs to be confirmed.
You know, the other interesting thing that when you mentioned about the sub-analysis about the data, that, you know, the more circulating DNA in EGFR positive patient, you know, we see this clinical practice, in the clinical practice, that these patients really tend to come in stage 4, you know, with diffuse Mets.
Yeah, yeah, and this was something where, so this was something where we had the first, I would say, flavor also in the Empower 10. There was this correlation related to this tumor stage and the nodal status with a higher number of patients with nodal positive tumors or higher tumor stages presenting with ctDNA positive tumors. So this is really fixing, or this is really in one picture. For the EGF receptor mutated patient, this is an interesting signal. And I think this has something to do that we are now, I would say we are also learning about additional characteristics of patients with EGF receptor mutation besides just the confirmation of the primary mutation. So there are additional features that play a role for our therapeutic decision, and the presence of the ctDNA might be another step to design our treatment. These might be patients who might benefit more from a combination than from a single TKA. Nobody really knows, but this is clearly something which needs to be explored.
Do you think TILs therapy and CAR-T are coming to lung cancer too?
Yes, they will come. So we have seen the first interesting signals coming out from modified TILs in pretreated patients with advanced non-small cell lung cancer after immunotherapy. The problem is, on the one hand, the tolerability is a bit ambitious, I would say. And the other point is the manufacturing process is very, very complicated. So unless we really have a striking signal of efficacy for the TILs and the CAR-T cells, we will have to wait some more time before we have the cellular therapies available also in non-small cell lung cancer. It's a very, very expensive and ambitious treatment. And so far, I would say the signals of treatment efficacy are a bit limited. We need more clear signs of efficacy in solid tumors in general, but in particular in patients with non-small cell lung cancer.
If we don't have any further question, we would like to thank Dr. Martin Rick for this beautiful and amazing presentation. I hope to see you soon in Jordan.
Thank you. Thank you so much.
You're welcome. Thank you. Thank you.
Good evening, everyone. It's a great pleasure for me to introduce our special guest today, Dr. Michel Ducroux. He is going to talk about the role of immunotherapy in hepatocellular carcinoma. Professor Michel Ducroux is the head of Gastrointestinal Oncology Unit and Gastrointestinal Oncology Tumor Board at Gustave Roussy Hospital. He is the professor of oncology at the University of Paris-Saclay in France. He trained in medicine, gastroenterology, GI tract oncology at the University of Paris-Sud. He holds a master's degree in biological sciences and a PhD degree in health sciences. He has held positions as assistant physician and professor of oncology at the gastrointestinal unit of Gustave Roussy and Paul Brousse hospitals. He is the former chair of the European Organization for Research and Treatment of Cancer, Gastrointestinal Tract Cancer Group, and is the former chair of the GI Group of the French Federation of Anti-Cancer Centers. He is co-editor for GI Oncology of the European Journal of Cancers. Prof. Ducroux has published more than 490 scientific articles focusing on the management of metastatic colorectal cancer, locally advanced metastatic pancreatic cancer, biliary tract, and hepatocellular carcinoma, in addition to the treatment of neuroendocrine tumors. Further to this, Prof. Ducroux is author to over 200 invited lectures in various national and international congresses. Please join me in welcoming Prof. Ducroux. Dr. Ducroux, the floor is yours.
Thank you very much for this presentation and this kind invitation. I was in Jordan, I think 5 years ago or something like that. I would have been happy to be there with you, but we will share discussions. That is something that is important, even if COVID-19 is a nightmare for all of us. So, and I was happy too to hear my colleague speaking about immunotherapy in lung cancer, because the fact is that for GI cancer, immunotherapy is now something that we are able to use. It took time because the first results were very good in other type of diseases. So first of all, I would like to show you my disclosures. It was quite fast, but I am working with all the industrial companies that are working in this field of GI oncology. First, a few words about hepatocellular carcinoma epidemiology and risk factors. Even if it is a little bit, it will decrease in the next years, probably because we are treating more actively B virus hepatitis and C virus hepatitis. It remains a very, very important and severe cancer in the world. This is the third cause of cancer deaths worldwide. And what is important to know is the fact that this disease is seen more in developing regions than in other regions of the world. And the etiology is also something that is different from one country to another one. I imagine that in your countries, the main etiology are viruses, C virus, and mostly C virus. I discussed yesterday with colleagues from Bahrain and Qatar, and they told me that their main problem for chronic liver disease is C viruses and a little bit NASH, non-alcoholic steatohepatitis. I am working in France, and as you know, in France we are consuming, we drink alcohol, and alcoholic cirrhosis remains a very important cause of cirrhosis and hepatocellular carcinoma in my country, unfortunately, I would say. The landscape of the treatment of hepatocellular carcinoma has changed quite rapidly these recent years. We had to wait for a long period of time to get active drugs in this disease. So sorafenib was the first step, but after that there were new, essentially targeted therapy, tyrosine kinase inhibitors that showed an activity in this cancer. But now we are coming in this field of immunotherapy with interesting data that I will try to share with you. The first data were presented, this is not first data, but this is the same, with monotherapy using pembrolizumab or nivolumab, and this is with results that are very consistent with these results that I have presented recently at the Congress of tislelizumab. In monotherapy, in pre-treated patients with sorafenib, or in first line, monotherapy with anti-PD-1 or anti-PD-L1 is able to give an objective response rate that is around 10 to 15%. So it is working a little bit, but not very well. Despite these results, quite, I would say, not too good, but not too bad, and considering the fact that this was a little bit a dessert, the possibility of treatment of hepatocellular carcinoma, FDA in US approved the pembrolizumab and nivolumab in second-line treatment after failure to either sorafenib or lenvatinib in first line. The fact is that it was not too bad for the US market. In Europe, we did not get this kind of approval, so we continued to participate to clinical trials. And in 2019, unfortunately, 2 randomized trials were presented. They have been published quite recently for the last one in Lancet Oncology. And unfortunately, they did not confirm in a randomized trial the first results that were obtained with monotherapy, either with nivolumab or with pembrolizumab. The trial with nivolumab was done in first line versus sorafenib, and there was a very, very small improvement that did not reach significant statistical significance. And the same was observed versus placebo in second line after failure to sorafenib with pembrolizumab. So I would say a bad experience, hope, and then a disappointment concerning the use of immunotherapy in advanced hepatocellular carcinoma. So the idea was to try something else, and especially to try to combine immunotherapy checkpoint inhibitors either together with 2 checkpoint inhibitors or with other agents, and for instance with anti-angiogenic drugs, because we know that hepatocellular carcinoma is sensitive to angiogenic agents, and there is a good rationale to combine even monoclonal antibody with anti-angiogenic effect with immunotherapy, and this was done by Roche with this combination, and Genentech with this combination of bevacizumab and atezolizumab. The fact is that in my unit, we worked on bevacizumab alone in the treatment of advanced hepatocellular carcinoma in the past, and it was not too bad in terms of results, but at this moment, sorafenib was approved, and it was considered that there was no place, no role for bevacizumab in the treatment of hepatocellular carcinoma. But it is easy to combine, and it has a synergistic effect with atezolizumab. And it was done in this trial, the EM-BRAVE 150 trial that has been published in the New England Journal of Medicine. It was a comparison in first line of sorafenib, that was the standard of care, versus this combination of atezolizumab, bevacizumab given every 3 weeks. It was possible to include patients with advanced first line, advanced locally advanced or metastatic patients with hepatocellular carcinoma. They had to have a good performance status, 0 or 1, and good liver function with a Chi-PUG-A, that is the way to evaluate the liver function, level of liver function that was good. But on the other hand, it was possible to include in this trial patients with a macrovascular invasion and extrahepatic spread. So it was not a very selected population of patients. I do not want to go into the details of this trial. It has been published, it has been presented in a lot of congresses, just to show that there was no imbalance between the 2 arms in terms of characteristics of patients. Going directly to the results, this is the best result in terms of overall survival ever published with hepatocellular carcinoma. The updated median overall survival was more than 19 months with a combination of atezolizumab plus bevacizumab versus 13 months with sorafenib. And this 13 months of sorafenib is not too bad. So it means that patients had an active treatment and they were quite well controlled by this treatment. but the new combination was clearly better, and it was better in terms of the you can see in all the subgroups of patients, with maybe exception is non-viral hepatocellular carcinoma coming on chronic disease that is non-viral chronic disease. I will be back to that in a moment. But if you look on the other main endpoint, that was progression-free survival, clearly there was an advantage in favor of the new combination, with again a very, very good hazard ratio of 0.67 and a median progression-free survival that was nearly 7 months versus 4 months with sorafenib. The forest plot did not show the same pattern, and especially for non-viral hepatocellular carcinoma, you can see that it seems that there was an effect of this combination of atezolizumab and bevacizumab. In terms of responses, again, I don't want to go into the details of all the trials, but what was interesting is that for the first time, we obtained in this trial, in this randomized trial, with, again, a non-selected population, or not very, very selected population of patients, an objective response rate of 30%. And if you look on the modified HCC RECIST criteria, it's even 35% of objective responses. So it means that for the first time in hepatocellular carcinoma, we have there a medical treatment that is able to be used, and there are, I will be back to that in a few moments, is able to become a neoadjuvant treatment, because the chances for the patients to have a decrease of the size of the lesion is not too bad. In the past, it was 10%. It is now 30%. So this is something that is working quite well, even in terms of objective response rate. We may imagine that this is a good treatment, but that there are some problems in terms of tolerance. In fact, the combination is a little bit more toxic than sorafenib in terms of bleeding, and especially of bleeding of esophageal varices. It has to be checked before you start the treatment, in the 6 months before the start of the treatment with atezo-bev. You have to control the esophageal varices with beta blockers, for instance, if there are esophageal varices, but it was not a major problem, and you can see that the number of patients with treatment-related grade 5 adverse events was only 2%, a little bit more than in the sorafenib arm, but it was not a major problem, even if we have to be careful with this kind of patients. Another very interesting and positive effect that was observed in this trial is patient-reported outcomes. Almost all the patients completed a quality of life questionnaire before the treatment and after a period of treatment. And what we observed is a delay in the deterioration of the quality of life of the patients that is given by this combination of atezolizumab and bevacizumab, and with some kind of plateau. And this is the advantage, as it is observed in a lot of other diseases. With this combination, we may observe some kind of plateau. Even in terms of overall survival, the plateau is very low. We are able to control patients for a long period of time. So it means that at this time, we have 3 treatment options for the treatment in first line of hepatocellular carcinoma. I would say a very old option, that is sorafenib, that I do not use at all at this moment. Lenvatinib, that remains an option for some patients, but I would say that for almost all my patients, I try to give them this combination of atezolizumab plus bevacizumab. But this is not the only combination that is on discussion. I would say that is evaluated in randomized trial, and especially we had very recently during the GI ASCO the results of the Himalaya study. Himalaya study was a trial evaluating the role of a combination of 2 checkpoint inhibitors, durvalumab, that is an anti-PD-1 inhibitor, and tremelimumab, an anti-CTLA-4. And the trial evaluated sorafenib as a control arm, durvalumab monotherapy, and combination of durvalumab plus tremelimumab. And what is interesting is that tremelimumab was injected only 1 time, 1 dose of tremelimumab, to decrease the level of toxicity that could be observed with this combination. The 3 arms were quite well balanced considering the different prognostic factors. And the only difference with the population that has been included in the EMBRAVE 150 trial is that patients with shrunk portal vein complete thrombosis were not able to be included in Himalaya as they were able to be included in the EMBRAVE 150. The primary objective of the trial was the overall survival for this combination of tremelimumab plus durvalumab versus sorafenib, and you can see that this was met with a hazard ratio that is a little bit less low than the atezo-bev combination, 0.78, but it is positive, statistically significantly positive, and with some kind, as I already said, some kind of plateau at 3 years. You have more than 30% of the patients that are alive. That's not too bad. The survival, the secondary objective was overall survival for durvalumab versus sorafenib. Durvalumab increased a little bit the median overall survival. It was not statistically significant, but not too bad, I would say. At least maybe for some patients, we can consider that, but in terms of approval, it will be difficult. But you can see that there is some kind of effect. In terms of forest plot, what we observed with this combination of durva-treme is that it is working in almost all the subgroup of patients. There we see some kind of difference, but it is always very difficult to evaluate the forest plot. It seems that it is working in HBV, it is working in non-viral, but it seems that for HCV, maybe it works a little bit less, but the number of patients in this group, as you can see, was very low. So I think this is only an effect of the low number of patients. What is a little bit strange, and I cannot explain that, and maybe we will discuss that together, is the fact that even if the overall survival was positive and clearly positive, there was no clear difference in terms of progression-free survival between patients treated with this combination of durvalumab and tremelimumab versus patients treated with sorafenib. And the median progression-free survival, especially, was completely similar at a little bit less than 4 months. So this is a little bit strange, but again, I think this combination is working. There is no doubt about that. And if we look on the percentage of objective response, you can see 5% for sorafenib. It was a little bit higher for EMBRAVE 150 for sorafenib, but there it is 5%. And when you compare to the other arms, you have 20% of objective response with the combination of the two checkpoint inhibitors, and you have 17% with durvalumab alone. That is clearly not too bad, with a disease control rate of 60%. So this combination is working with a safety and a tolerability that is quite good. Even if there is no problem in terms of bleeding, because this kind of toxicity that is observed with bevacizumab is not observed there with this combination of two immunotherapies. But you can see that the treatment-related adverse event leading to death was very similar to what has been observed with atezo-bev. This is 2% versus 1% with sorafenib. The problem with sorafenib is that probably the toxicity is less severe, but for the patients, it is a toxicity that is very problematic with diarrhea and food syndrome. And in terms of day-to-day life, this is a major problem for our patients, and everybody knows that about this agent. What we can say also is that I already said that monotherapy is not working in hepatocellular carcinoma, but I can say that a combination of immunotherapy is not working always, and especially because we got very recently the result of this trial, COSMIC 312. That was a trial, first line, comparing with the same control arm, sorafenib, cabozantinib, and combination of cabozantinib plus atezolizumab, again in a population of patients, a large trial, more than 800 patients, with Child-2A good performance status, so a very, very comparable population of patients that were treated in the Himalaya and in the EMBRAVE 150 trial. And the progression-free survival was positive in favor of the combination. So this was the first primary endpoint, and it has been met. Cabozantinib and atezolizumab demonstrated significant improvement in progression-free survival versus sorafenib, with a difference that was 4 with sorafenib, very consistent across all the studies that I presented to you, and there 6.8, so something very close to 7 months of median progression-free survival. Unfortunately, in terms of second primary endpoint, that was the overall survival, this combination of cabozantinib and atezolizumab did not show any improvement versus sorafenib, with a median overall survival that was 15, very high, I would say, for sorafenib, but it was 15.5 as a median, and for cabozantinib and atezolizumab, 15.4, and we can see that there is a complete overlap of the survival curves. So it means that even if it seems that combination of agents, active agents, is something that is working, including immunotherapy, is working in hepatocellular carcinoma, it is not always the case. And I am sure that this combination of cabozantinib plus atezolizumab will not become a very, very important and interesting treatment for our patients. But we are waiting for more results for other combinations that are at this moment that have been evaluated in phase 3, and the results are pending. This is especially the case with this combination that has been approved in a lot of different cancers. This combination that, to my opinion, is a very good combination, very active combination, pembrolizumab and lenvatinib, because lenvatinib is an active drug. I consider it is, I already said that it is better than sorafenib when we use it as a monotherapy. This combination with pembrolizumab seems to be quite active and synergistic, and the first results were very, very good in terms of overall objective response rate, and even in disease control rate. You can see it's even better than what observed with other combinations. So we are waiting for the results of that. A point that could be a difference with the 2 other combined treatments that we will have in the near future, probably that we will have to have a look on the toxicity of this combination in a very large randomized trial. Another combination that we are waiting for the results in phase 3 is this combination of nivolumab plus ipilimumab. It has been tested in hepatocellular carcinoma in this CheckMate 040 trials that has been published quite recently in JAMA Oncology, with 3 different schedule of administration of nivo plus ipi, either every 3 weeks for 4 ipilimumab doses, and then maintenance with nivo. And this is this schedule that has been selected for the phase 3. And we will see in the arm A, and we will see in the future what will be the results of that, and the comparison with durvalumab that is very, very similar in terms of type of drugs that have been used. You can see that the level of response rate remains quite similar, 30%. So this is very, very, again, very consistent across all the different type of combination. There are some outstanding issues, and I would like to show you, and I am coming to the end of this talk, so I think I will be on time. Something that has been published by Aber. This is a meta-analysis that has been published last year in Gastroenterology. Just have a look on this part. That is evaluating the role of immunotherapy in patients according to the etiology of the underlying chronic liver disease. And in red, this is viral etiologies, and in green, this is non-viral etiologies. So at this time, they used CheckMate 489, EMBRE 150, the Keynote, and you can see that when you have a look on that, it seems that it is working a little bit more in viral etiologies versus non-viral etiology. Again, this is not the case in the last trials that has been presented. It was not included in this meta-analysis. With durvalumab, it seems that it is working also very well in non-viral etiology, but this is something that we have to keep in mind, and we have to continue to work on that. And the future is clearly, I showed you a lot of data concerning advanced disease, but the future is clearly to put immunotherapy before, so in less advanced settings, and especially in patients that are receiving transarterial chemoembolization, TACE, with more localized disease. And there are ongoing trial evaluating that. And already some results, very recently at the ESMO meeting, Arndt Vogel presented this trial evaluating the role of a TACE combined to nivolumab in patients with intermediate stage HSPC in this IMMU-TACE study. And the results were not too bad. You can see in terms of progression-free survival, in terms of objective response rate, this is quite interesting, more than 70%, and a quite good overall survival. This is only a few patients. We cannot draw any conclusion, but there are at this time ongoing phase 3 trial. For instance, this one that is run by Joseph Lovett, evaluating the role of combination in patients with TACE that are after that randomized. You can see lenvatinib, pembrolizumab plus TACE versus placebo plus TACE, and we will see in the future if the addition of lenva pembro is improving the results in TACE. So we may imagine that in such patients we could get very, very long overall survival. That is something very interesting in this very severe disease that is hepatocellular carcinoma. So I am finishing the presentation, and I will answer to your question with this conclusion. And after that, I will show you the current guidelines. Clearly, immunotherapy has already a major role in the treatment of hepatocellular carcinoma in first line. I forgot her. And especially this combination of atezolizumab and bevacizumab, that is clearly the new standard of care for the treatment of advanced hepatocellular carcinoma. We will see how durvalumab plus tremelimumab, that is another new combination and active combination versus sorafenib, will take its place in comparison with atezobev. I would say that I consider that the results are a little bit less positive, but for patients, when we are afraid of any kind of toxicity with anti-angiogenic agents, it could be a very good option. And we are waiting for the results of this combination of nivo plus EP and pembro plus lenva, and probably it will come this year, 2022, in advanced disease. And I think that we have to continue to work, and especially to include patients in trials evaluating the role of immunotherapy combined either to surgery or combined to tests. Something that we cannot combine is immunotherapy and liver transplantation. You know that liver transplantation is a standard of care for small hepatocellular carcinoma. Unfortunately, it's impossible to do that, but we will see in the future. So if we look on the guidelines, the NCCN guidelines at this time included atezolizumab as a very important standard of care for these patients with inoperable disease. This is a very important new options, and it was exactly the same in the ESMO guidelines for the treatment of hepatocellular carcinoma. Thank you very much for your kind attention.
Thank you very much for your nice presentation and new update about immunotherapy. I have one question for you, Doctor.
Yeah.
In the context of the new phase 3 trials about the combination that showed the efficacy of immunotherapy in combination with multi-tyrosine kinase inhibitors, did you have any criteria to rely on for choosing the best treatment option for your patient, especially in the absence of biomarkers to drive our treatment? Or you still consider atezolizumab, bevacizumab, the golden standard of care as first line, and because this trial showed the best outcome, and it's still the first line option for this category of patients?
Yeah, I think I already discussed that a little bit when I presented the data. The fact is that In terms of median overall survival, the best results have been observed with Atezobev. In terms of objective response rate, 30%, it's better than 20% with Durvalumab. So clearly, this is Atezobev at least remains a very important option in first line. But we have some patients with huge esophageal varices that are difficult to treat, and for these patients, clearly, the combination of Durvalumab plus Tremelimumab will be a very, very interesting option. We have some patients also with hypertension who do not tolerate this combination of Atezobev, and to have another option is something that is very, very interesting and very important for our patient. And again, the level of toxicity of Durvalumab is not too bad. So to my opinion, this is a good option. I would be a little bit more for the moment to keep Atezobev as the first main option for these patients.
Did you consider Himalaya trial results more, considered more safety profile, especially the bleeding risk was less compared to Brave trial?
Yeah, absolutely. Yeah, this is the main difference in terms of tolerance between the two trials. We know that there is an increased risk of variceal bleeding with Atezobev. So the fact is that when we go into the details of that, we observe toxicity in terms of GI bleeding, mainly in patients with esophageal varices that were treated in the past. So quite important problem related to esophageal varices, even if they were treated. If you have a patient without esophageal varices or with very small esophageal varices, the risk of complication is very, very low with this combination of Atezobev. But if I get access to Durvalumab, this is sure that if I see a patient, I perform an endoscopy, and this patient has a huge esophageal varices, I will go directly for Durvalumab, and I will treat the esophageal varices. I will not go, as I am doing today, for treatment of esophageal bending, for instance, of esophageal varices. I start Atezolizumab, and I add Bevacizumab only when the esophageal varices are completely eradicated. I will do directly Durvalumab in the future for patients clearly. So again, I would say that it is a little bit complementary more than a complete face-to-face concurrent.
Last question. Do you have any explanation, doctor, why most of the solid tumors about immunotherapy, they have subcategorization of their patients based on the PD-1, PD-L1 status? Why this is lacking in our hepatocellular carcinoma phase 3 trials? I don't know why.
This is a very good question. You know, this is not so clear in other GI diseases. What we have, yes, it's true in gastric carcinoma because we consider that now the addition of immunotherapy is active with chemotherapy when TPS is 5, more than 5. It is not working if it is less. But it has been looked at for hepatocellular carcinoma, and especially in Atezobev trial. There is absolutely no difference in patients with PD-L1 low and PD-L1 high, probably because this, I would say that this marker is not a very, very relevant marker, but I don't know, really, I don't know why.
Yeah. Other questions, please, participants? Any other question? Okay, thank you so much for this nice presentation. Thank you for time and effort in your presentation.
You're welcome. Thank you very much for the invitation. It was a pleasure.
We have just 5 minutes break till our last lecture in the conference. Dr. Abdullah will moderate the last session.
شويه يا دكتور. لا انا بقرب لك الميكروفون عشان افهم الصوت يطلع كويس ان شاء الله. اوكي.
الله يعينهم 3 أيام متواصلة سهل. Dr. Mervat, can you hear me?
Unmute her. Unmute. Unmute.
Dr. Mervat, can you hear me? Can you unmute yourself? We cannot hear you. Hello? Dr. Mervat? If you can hear me, please unmute yourself. شايفها انت؟ اشتغل معها. ما صار تواصل معها. We're waiting for our next speaker, who seems to have some technical problems locally. Hopefully, she will manage to solve them soon.
I cannot unmute myself. I cannot unmute myself.
Okay, fine. We hear you loud.
Am I unmuted now?
Yes, we can hear you loud and clear. Thank you very much.
So I'll start at the beginning. If you don't mind, I will not take much of your time.
Okay, let me just introduce you, Dr. Mirbat.
Thank you, sir. Thank you.
Dr. Mirbat Mohammed Matar, who is our next speaker, and the last speaker in this particular conference. I'm happy to say that Professor Mirbat is a well-known expert in multiple myeloma regionally and internationally. And after graduating from Cairo University, she continued her studies in the same university, obtaining master's degree, then MD degree. Then she went into the academic ladder, and she achieved professor of clinical hematology in Cairo University. Practices mostly in Qasr al-Aini. Dr. Mirbat is an author of multiple papers published in known medical journals, and she's going to talk about the role of carfilzomib on the when efficacy meets convenience in multiple myeloma. Dr. Mirbat, you have roughly 30 minutes to talk, and I look forward to your presentation. Thank you.
Thank you, sir. I'm sorry for the delay, but can you see my slides?
Not yet.
Not yet. Okay, I'm sharing. Okay, can you see my slides right now?
Not yet, not yet.
Okay, apparently there's a big problem here because I'm sharing my slides and still you cannot see them.
That's what he needs to do.
Okay, can you share your slide? Can anybody share the slides on their side, and I can just ask them to flip the slides?
Let's see if we can.
Could you please stop the sharing and restart the sharing again? It's quite easy, by the way. Could you try to stop it and restart it again? The sharing.
Okay, no, I'm not sharing.
Okay. Dr. Rami?
I'm not sharing right now.
لحظة بس دقيقة.
تفضل.
مشكلة.
Can you give me the possibility to share? I'm Rami from Amgen.
I'm not sharing right now. I'm not sharing.
سوري سيد رامي انت حابب تعمل شير من عندك يعني بس نفهم منك.
Yes, I can share من عندي السلايدز.
تفضل نبدأ نغلبك.
بس اعطيني مش عم بعمل شير، بحكي يو كانت شير.
لحظة مش ماخذ هو شو اسمه. اوكي جرب هسه، جرب سيد رامي. تمام تفضل ان شاء الله. تمام هي طلعت سيد رامي.
Yes, thank you. Okay, next slide, please. Please. So it is a pleasure and honor to be sharing with you these slides, and a pleasure and honor to be sharing this very informative meeting. And as you can see, myeloma in Egypt, there's an age standardized incidence rate of 1.5 per 100,000, with a frequency of 0.7% for both sexes. It is more in men than in women in Egypt. And multiple myeloma represents 8.7% of all hematologic malignancies in Egypt as of 2014. Next slide, please. So about multiple myeloma in Egypt, we had a descriptive study of 217 Egyptian patients in Qasr Al Aini, Cairo University, back in 2013. Next slide, please. And next slide. Yes. And as you can see, we have younger ages, and I'm sure that in Jordan you do have the same. We had 38% between 50 to 59 years of age, and 39% between 60 to 69. Of course, there were majority of IgG kappa, and males more than females. So as you can see, these are younger ages. Next slide. Next slide. And so go back, please. We are expecting these patients to relapse once, twice, and many other times because they are younger and they have less comorbidities. So we have to look forward not only to first-line therapy, but also to first and second relapses, and try to make sure that relapses are far and far in between so that they can live longer and longer. And this is our problem in the region. Next slide. Of course, we all know that to attack myeloma cell, we usually start with the first regimen, which is VD or VRD. Next slide. But then after a while, we look for others. We look for second generation inhibitors and others such as monoclonal antibodies to help combat resistant or relapsing myeloma cells. Right?
بس الصوت كأنه راح دكتورة. دكتورة سمعتينا الصوت راح، أو السيد رامي إذا سمعنا الصوت راح.
هو راح صوت دكتورة ميرفت من هون. I'm trying to connect her. أعطيني بس 1 minute.
أوكي مش مشكلة.
You hear me now properly? Can you hear me?
تمام دكتورة تفضلي. إن شاء الله. تفضل دكتورة.
Okay. So we need to think of further escalation relapsing myeloma patients, especially in early relapses. Next slide, please. Next slide. Please. So flipping through the next 3 slides, as you can see, there are many, many options for first relapse and further relapses. And we need the next slide and the further one, please. Next slide. So these will include many medications. But looking at the first relapse and even the second relapse, maybe we'll be looking at the second generation proteasome inhibitor, which is carfilzomib. It is a selective proteasome inhibitor, and it is an inhibitor that is a reversible inhibitor, and becoming a reversible inhibitor. Maybe it will have more action than the first.
دكتور انا غلبك الصوت بروح بيجي اذا في مجال تثبت الميكروفون عشان ما يضلش يفلت كانه بفلت الميكروفون او يعني لوز هيك فيه او شيء غلبك. سمعتيني دكتوره؟ عم بفصل الصوت دكتوره اذا سمعتينا. الو يا دكتوره اذا سمعتينا بفصل الصوت بروح.
نكست
دكتوره الصوت عم بروح يا دكتوره. دكتوره الصوت راح تماما يعني ما في صوت يعني من نص دقيقه ما في صوت.
Can you hear me now? It's better.
دكتور اسمحي لي بس الصوت عم بروح يعني بروح بختفي الصوت بيختفي فترات زمنيه وبرجع.
I'd rather hear me better.
دكتورة بس غلبك اذا الميكروفون لحظة بس تحملينا شوية. دكتورة اذا الميكروفون يعني مش ثابت الجك تبعه مش بس تأكدي من الجك تأكدي من ثبات الميكروفون تأكدي من اسلاكه بس دكتورة غلبك اذا في امكانية.
It's not working. Hello?
دكتورة الصوت مش واضح في مشكلة في الصوت. دكتورة في مجال تعملي إعادة تشغيل لجهازك سريعا هيك لأنه في مشكلة واضح جدا يعني أو إذا بتحبي تفوتي من التليفون يعني من الهاندسيت إذا في مجال بكون أحسن يعني.
اكزاكتلي دكتورة سنس انه انا ام شيرنج السلايدز من عندي من اللابتوب سو ممكن حضرتك تجوين من الموبايل بجوز يكون احسن.
Hello? 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 Can you hear me?
احنا سامعينك، تفضل دكتورة.
طب اتفضل. Can I see the slides, please?
اوكي سيد رامي،
So
الله بيدك.
we are discussing carfilzomib here, which is the second generation proteasome inhibitor. It is an irreversible proteasome inhibitor. Let us look at the second slide, please. The next slide. I need the next slide. Yes. And as you can see, if you compare between the use of Revlimid versus Kyprolis, KD versus VD, you will have a better response, specifically progression-free survival, better response carfilzomib versus Velcade in relapsed state. Next slide, please. And carfilzomib is not only used as DEXA, it can be used with many different combinations with very good results anyways. And we all know that with multiple myeloma, we only look at progression-free survival as our goal. Overall survival also looked for, and also the response rates. And carfilzomib with many combinations proved effective in the setting of relapsed myeloma. Next slide, please. Next slide, please. So let us start with Aspire study, which is carfilzomib Revlimid DEXA versus Revlimid DEXA in patients that have relapsed, first relapse or maybe second or third relapses, and they were stratified according to the beta-2 microglobulin, according to the receiving bortezomib lenalidomide before. And even cases that had received bortezomib, they only chose cases that showed some response to bortezomib, so that we can, in relapse, give carfilzomib. As you can see, the study included patients with carfilzomib with a dose of 27 milligram per meter squared to be given over 10 minutes IV infusion. And carfilzomib was stopped after cycle 18. And I think this was rather wrong because they did not continue. And if you can look at the results, both in early relapses and in late relapses, there were very good responses with carfilzomib addition versus alone. Next slide, please. Next slide. How about the extended assessed medium progression-free survival? And there was again in medium progression-free survival with the use of carfilzomib of 26.1 months versus only 16.6 months in the RD arm. Next slide. And this was also true if the patient had had only one prior line of therapy or more than one line of therapy, or if the patient had had prior bortezomib treatment or no prior bortezomib treatment. All cases responded very well to carfilzomib versus non-carfilzomib RD. Next slide. Next slide, please. So study compared full dexamethasone versus Velcade dexamethasone. Here the dose is higher. It is 56 rather than 20 milligrams per meter squared. And they also cases that were relapsed, and they compared these cases. Let us look at the results, please. Next slide, please. Next slide. As you can, both in early relapse and in late relapse, the use of carfilzomib was much better than of bortezomib in the relapse setting. Of course, late relapses usually respond better than early relapses, but this is to be expected because patients with early relapse probably will fare worse anyway. Next. How about progression-free survival, which is very, very important in our cases? There was again the median progression-free survival with the use of carfilzomib versus the use of and this was to control slightly. The next slide. Yes, of course, if you use carfilzomib early, it's going to give the best results. So first, relapse patients will respond better. Second, relapse or third relapse cases. Next. So patients that have had exposure before, patients that have had lenalidomide exposure before, whether this or that, the use of carfilzomib gives better results, better progression-free survival. So even if the patient have had use before, so proteasome inhibitor before, this does not mean that second generation proteasome inhibitor is not going to work. No, it is going. It's going to work well. Next slide. Next slide. Yes. How about the overall survival? Even the overall survival was much better used versus Velcade in the relapse setting. And not only giving progression-free survival, which is nice, but we're also extending the overall survival of our myeloma patients. Next. Next slide, please. This was also, the progression-free survival was also good both in early relapses and in late relapse patients. Of course, with late relapse patients, you're expecting a progression-free survival. But even in the early relapses, still we gain more time, we give more time to our patients that are progression-free. Next slide. Next slide. Yes. Now, this is arrow study. And the arrow study here, we're saving the patient time and effort. We are looking at if the patient needs to come for an eye injection only once a week rather than twice a week. And here we are comparing once weekly carfilzomib versus twice weekly carfilzomib. And these patients, because they are receiving a big amount of carfilzomib, 70.
ما هو كلامك ضابطة العلم بعرف والله بعرف ما في مشكلة الله يعافيك
Please, I need the next slide if you mind. And as you can see, they were very good response. To twice a week, and so the overall response, first response was much better when you twice a week injection of cartridges. Please. Next slide. Next slide, please. And if you don't mind.
Michael Dure.
السلام عليكم.
تفضل. وعليكم السلام، تفضل.
This is Mohammed Osama, the medical manager for oncology and hematology for Amgen Egypt and Levant. I'm very, very sorry for the technical issue Professor Mervet is facing with her internet connection, I guess. I tried to connect with her several times, and she tried several connections and the same result with breaking down of the votes. So on her behalf and on behalf of all of Amgen, I'd like to express my gratitude that we are with you today and I'm expressing my sorry for the technical issues that was happening during the presentation. Thank you so much. I hope you accept our apologies.
Okay, okay. Well, since we are so keen to hear from Professor Mirbat because of the importance of the topic, and on behalf of the JSH, I would like to thank her and thank Amgen for supporting this activity. We promise all of you that this talk will be rearranged again after the end of this conference at a convenient time, mutually agreed upon by us and Professor Mirbat, because I think what she's going to show is extremely important. We have already seen limited slides. Unfortunately, because of the technicality, she could not continue on this. So I wish to thank her and thank our Egyptian colleagues for their collaboration, and thank Amgen for supporting this activity. Thank you.
Our pleasure. Thank you so much. Thank you.
Okay, so let me, being a chairman of the Jordanian Society of Hematology, at the end of the 3-day superb conference, I would like to thank all of you who endured attending 18 continuous hours of lectures, presentations, and talks with little or no breaks. And in general, the conference has went smoothly with minimal technical problems as compared with our first conference. This 9th conference is in tradition with our previous conference at the level of talks and the level of speakers. The level of speakers is superb. I think we had gathered some of the best experts in the field. The topics were very carefully selected, and this is thanks to the scientific committee chaired by Dr. Ghadira Abdin, to whom I would like to extend my real gratitude and thanks. And it was the support of all the members of JSH, which is extremely encouraging. And as you can see, this activity cannot have been done without the support of various players. Among those, I'm going to mention the Ministry of Health in Jordan, Novartis Pharma, Pfizer Pharma, Roche Pharma, Hikma Pharma, MSD, AstraZeneca, Novo Nordisk, Amgen, MS Pharma, Janssen Biologics, Sirona Merck, Mundipharm, and Newbridge. In addition, we have hosted 23 international speakers, mostly from Europe, USA, and Canada, and the countries whom we hosted speakers from are Canada, United States of America, United Kingdom, Spain, Germany, France, Egypt, Italy, Egypt, and Lebanon. It's obvious that the audience, from the feedback I have got, are extremely grateful and very happy to see such level of talks. We will continue our activities in a yearly manner. And next year, our conference will be held between the 22nd and 24th of February. That's Wednesday, Thursday, and Friday, exactly the same as this year. And we would love to see more of you. We would love to see more participation from our regional colleagues. Just to remind everybody, all the talks and presentations are being taped and videotaped, and they will be on the site of the society. So if you just link with the site, and you will see these being, you can download them, hear them again. As for the CME certification, we have still some issues with the Jordanian Medical Council, and hopefully this will be solved fairly soon. Once we solve the issue with the Jordanian Medical Council, we will we will certify the CMEs, and each of you will be able to download and receive his CME accordingly. At the end, I would like to thank all the supporting staff, Suhair, Midhat, Abdul Qadir, and the team who have been extremely helpful and who have maintained our technical microphone as well as our screens in superb shape. And I'd like to thank you all, and I hope to see you in our conference next year. Thank you very much and good night.
Thank you all.